bit about my background first of all. So I'm Steph Such and I work now as the pre-assessment nurse manager. I've worked at the Trust for over 25 years. I've been on various medical wards throughout the Trust. I've worked in PALS before I came into pre-assessment, so I've not always been here. I moved here about 6 years ago and became a manager of the unit about 4 years ago. So that's me, and
I'm Claire Cunningham. I'm one of the anaesthetic consultants at the Trust. I started here about 12 years ago, and I took over as pre-assessment lead probably about 7 or 8 years ago. So I thought we'd start off by saying, Steph, run through what we were like pre-COVID and how pre-assessment ran, and then say what we've been doing since and the major changes we've made in the last couple of years.
So when I first joined the team, and until you know, quite recently, we were split over 2 sites at both Ashford and St Peter's, and within 2 sites in each of those sites as well. So we had 4 areas to work from, to split our workforce from. We only had 6 clinic rooms to be used by all of our nurses. We didn't have any dedicated reception areas or waiting areas for our patients. They were all shared areas with various outpatient clinics. We also had a situation whereby when patients attended, they had to walk some distance to different departments to get their blood tests, get their ECGs. And we to have anaesthetic notes reviews or an anaesthetist to see a patient was really quite a challenge when we were split over so many areas. We had to send the notes to anaesthetics and wait for them to come back and be tracked before we could get our patients organised and assessed for surgery. So it's quite challenging logistically to manage nurses within 4 areas, trying to pull a service together. It was very, very complex and very, very stressful at times, moving things around. We'd long campaigned to have a unit together and on one site, and during COVID we moved to work only at Ashford as a green site in various rooms throughout the hospital. Whilst supporting other areas, we kept our same day pre-assessment service running for any patients who were attending cancer appointments and things. They'd come straight through and have a pre-assessment done then. Or we'd do a few booked appointments with minimal staffing at Ashford on the green site. But as soon as our work started ramping up again and increasing, it was clear that we needed some dedicated space. Claire and I worked very, very closely with Andrew Grimes and other managers to try and look where we could find some clinical space that was suitable. And so space was identified here at Ashford on level 2, where the appointments team used to work. I think a lot of the records that were held on level 1 have been moved out to storage so that appointments teams could actually move into those non-clinical areas, and level 2 could be repurposed as clinical space for pre-assessment. It was previously one of the old wards in the Trust block, and it actually is right next to blood tests, next to phlebotomy. So working really closely, you know, to plan what we needed and what this service required to be able to deliver for our patients. We've managed to get a reception desk, a dedicated reception area with some seating out in the lift lobby area, some seating along the corridor before we enter the space. We've got 7 clinic rooms where our nurses and consultants and anaesthetists can now see our patients. We also have an assessment bay where we can, our healthcare assistants can see our patients. We can do all our ECGs in-house. We're right next door to phlebotomy, so all the blood tests are done here on site for our patients, making it a real one-stop shop, one-stop service. So previously we could probably see a maximum of about 55 patients a day. Now we can see up to 80 patients a day, which is quite a difference. That's using the same number of nursing staff. I think the biggest change for us is the fact that we now have anaesthetic presence within our service, within our clinics, for 8 out of the 10 sessions a week.
So that's made a huge difference in terms of, because previously the notes, we used to get purple folders, used to go around to our pigeonholes in the anaesthetic department at St Peter's, and you would try and review patients in between, in your lunch break, in your coffee break, during the middle of a busy list. So it was very difficult to turn notes around, and they would often sit in the anaesthetic department for up to a week before they were sent back to pre-assessment. Now, for 8 sessions out of 10, there's a consultant anaesthetist present in the pre-assessment department whose job is purely to focus on looking at notes of patients who the nurses are unsure about. If patients need to be seen on the day, for example, if they've got a potentially difficult airway, or if they've got certain medical problems, we can see them, assess them on the day, and hopefully get them ready for surgery and get them past it within 24 hours. So it's made a huge difference. We've been pushing to get an anaesthetic consultant presence for 10 sessions because we think we can. There is the volume of work. We end up looking at 15 to 20 sets of patient notes per half day. So there is the volume of work to do. So we're hoping that within the next job planning route, we'll be able to get 10 sessions covered, all 10 sessions. And we also have two high-risk clinics per week. So we have 8 high-risk clinic slots per week as well for the more difficult and challenging patients. So having anaesthetists here has been worked really well. I think the anaesthetists find it very interesting. You never quite know what is going to pop into your pigeonhole to look at, and it's something very different to what we've done before. And I think the nurses feel very supported by the anaesthetists as well. So it works really well. It's a good collaborative approach.
It is. It is. We continue to run as a nurse-led service, so all the decisions around the day-to-day management within our guidelines are purely nurse-led. But having the anaesthetist who can actually see a patient on the day when they are in the clinic, rather than have them having to return, it just makes such a difference. And anything that's really complex, really difficult, if a patient appears unwell and needs immediate attention or treatment, then it's very easy to initiate those pathways for our patients now. It's made a really big difference. So even before COVID, we started to do some My Pre-Ops for our patients, which is where we had a patient portal so that patients could fill information in before they came in to see us. We are continuing that in a slightly different format. We're going to move on to version 2 of that, which should support us being able to do some more virtual pre-assessments, which is what we want to try and aim for. That will run alongside our push to do more same-day service pre-assessments. So any patients that attend a surgical outpatients appointment now that have a decision that they need surgery and a TCI completed, we are able to see them on the same day at Ashford if they are sent by the consultant when that TCI is completed. For example, they'll be seen in the clinic. Yes, sir, you need to have a hernia repaired. We'll list you for that surgery. You require a pre-assessment. If you'd like to go up to the pre-assessment desk on level 2, that can be done today, or that can be undertaken today for you. Alternatively, you can book an appointment of your choosing when you wish to return and have that done. So a lot of benefit in that. The patients can have everything done on one visit. It's very good. We don't get DNAs, people missing letters, etc., etc. And it gives us plenty of time to optimise patients who may need, more investigations. They may need echocardiographs, they may need respiratory test function. We may need to get notes from other trusts. There's lots of different things we can do if patients are pre-assessed very early in the pathway. We've got the space, we've got the facilities to be able to do that now for patients. So.
We ran it before COVID, but now that we're on one side, it makes it much easier. We never turn patients away, even with staff sickness. We never cancel any patients. We're able to move things around. Staff's very good at managing the staff and the team to make sure that patients don't suffer and don't miss their appointments. So we managed to get everybody seen on the day if we can, if it suits them to stay. Other things we want to do is, in terms of moving forward, we want to do, as I said, more virtual pre-assessments. And the other thing is, if people are seen at Ashford, for example, whether we can get the outpatient staff to do blood pressures, height and weight, to stop the patients having to come to Ashford for a pre-assessment. So there's things we're looking at moving forward to try and stop patients having to come to Ashford if they're seen at St Peter's, because I know there's been pressure on the trust from that point of view, because not everybody needs to come to the pre-assessment part and be seen face to face. So we're trying to work more virtually to try and make it easier for patients and get them onto the list more quickly. And I think one of the things that holds us back is the MRSA policy within the trust. There's no consensus among wards and surgeons about who needs MRSA. So that's an ongoing discussion at the moment, because if we don't have to MRSA swab people, we often don't have to see them in pre-assessment. So that's something that needs a consensus opinion from within the trust, is that who needs a pre-op MRSA and who doesn't. And that will definitely help us moving forward.
The other thing that we also need is to look towards having an ECG upload facility, because that would mean if a patient was seen in outpatients, rather than printing a paper ECG that needs to come to us, it would automatically be uploaded onto Evolve or Cerner. That's currently not built into any of the systems. I pursued that quite rigorously a few years ago. However, that's never been funded, but that is certainly something that would make quite a big difference to us if an ECG could be done, say, at Walton or, you know, at St Peter's or somewhere else, and then it could be reviewed by our anaesthetist after a virtual appointment. So that would be really helpful for us. That's something that we do need.
So Steph and I do a lot of work on the day cancellations. So every week we get a list of the cancellations within the Trust of Elective Surgery on the day, and Steph and I go through every single cancellation that happens from the week before, look at the reasons why they were cancelled, and if there's anything we can do within the pre-assessment department to try and prevent those happening. And then we sent an email out to the various ADOs, the divisional directors, the clinical leads for various specialities, so that people are getting feedback about why patients are being cancelled, to try and prevent these happening in future. And it'd be, you know, sometimes it's related to lack of beds or to do with booking issues. So we feed these back to the service managers as well. But one thing we've reintroduced in the last couple of months is phoning patients a week before surgery. So the patient get a phone call from a band 2 or band 3 HCA or support person, and we have a list of questions, of structured questions they ask. So, for example, do you know what to do with your fasting? Do you know what to do with your medication? Has anything changed since you came to pre-assessment? Have you got any new medical problems? And we picked up quite a few. That's a really useful service we've started, because you pick up quite a few people who they've forgotten that they have to come and get a grip and save done. They've forgotten that they need to have their COVID test done. So it's just, you know, they may have been seen 6, 7, 8 weeks ago and they've forgotten the instructions the nurse gave them. So ringing them a week before means that we can just give them a gentle reminder, because patients forget to tell you that they've had a heart attack 2 months ago and haven't told anybody. So we find it really useful to ring them up. At the moment, Steph's managing to balance it within the team, but we are really short on the admin side. Unfortunately, Steph doesn't manage the admin team within pre-assessment. So we're really short with suitable people who could ask these questions, because it doesn't have to be a qualified nurse who asks those questions, because there's nursing support and anaesthetic support. If they have any queries, they can always approach somebody, but that's something we struggle with, is having the staff to run that. And actually it's a really, really useful service.
And it's very, very well received by our patients. The feedback that we get when the nurses call out to them is like, oh my goodness, I'm so glad you've called. I've been getting worried. You've put my mind at rest. So I think just on the patient satisfaction level, it makes an immense difference to be able to do that 5-minute phone call to the patients. It's twofold. It prevents the cancellations. It means the patients are prepared adequately. They're not going to be cancelled, and their mind's put at rest. They feel they've had a really good service when we can do that. So, so alongside when we look at the cancellation lists and everything. So Claire and I, if anything, any patients are cancelled potentially due to pre-assessment or anaesthetics, anything that we can look to improve from the mini root cause analysis. I do a meeting every week with my team of nurses. I just call it my pre-op team briefing every Tuesday at 1 o'clock. Alternate weeks, Claire is present in the unit, so she's involved with that as well for anaesthetic input. So it's a general discussion about anything that's happened, any day texes, any cancellations, looking at what's happened, why it's happened, how we can change it. I ask for suggestions from all the staff at what they think. We do lots of mini teaching sessions, as well as cascading information out, and that happens every Tuesday. Really, really well received by our staff. They feel extremely valued. They're totally up to date with everything that's going on within the team. And they, you know, it's a forum where they can bring out different ideas, issues that are cropping up on a week on week basis. So we have a continual improvement. We don't have to wait 3 months for a big meeting to try and put things to improve things. We have a constant, you know, feeling of we can improve all the time, and people buy into that. The staff really like it like that. We get a lot of engagement from our staff, to a point where, touch wood, I don't think I've had any staff leave for quite a number of years. They actually really enjoy working here. So we've got a very, very strong, stable team in pre-assessment, which we're extremely lucky to have in the current climate in the NHS. So
I think part of that's down to Steph's management as well. I mean, we work very well together. We do. Team.
We do.
But Steph, I think she uses her northern charm to sort of put the staff at ease, and I think it works really well. I think staff feel very supported. So we've probably talked enough. So I don't know if anybody has any questions about anything we've said, anything they want to ask.
So lovely. Thank you for that. I think that's a really great staff story, and I'm sure there's going to be questions. I'll ask people when they ask their question if they could introduce themselves first, so you know who they are and kind of what their role is. I'd just like to kick off because I think it's a great story, and I think you can help us here because one of the things on our agenda at the moment is improving the rate of patient feedback. So, you know, the electronic feedback that we get, and if you've got 55 to 80, hopefully pretty happy patients a day, that would be really helpful. I don't know the extent to which you try and persuade your patients as they come through, but
well, actually, interesting you should say that. We've actually one of our registrars, the anaesthetic registrars, we've given her an audit project, and she's actually started a patient feedback survey this month. So we've got a QR code for a patient feedback thing. So that only has just started in the last couple of weeks. So hopefully in the next month or two, she'll have reasonable numbers of feedback from our patients.
Brilliant. Look, I'll give other people a chance because I can see there's lots of questions coming in, and I'm going to kick off with Jane Dale.
Thank you very much, Steph and Claire. I'm Jane, and I'm one of the non-executives, and I chair the Quality of Care Committee. So it's with great joy that I hear your story, that you've been able to make those improvements in actually quite a difficult time. So really well done. And from a patient point of view, it must make such a difference to have that one-stop shop. I mean, I know one of the irritations is all the visits, particularly if transport's an issue. So that's a brilliant thing. My question really was, well, my ask, first of all, before I ask the question, is that can we consider the two things that you said around the ECG loading, which I think is something we probably need to look at operationally, and secondly, the issue around the MRSA consensus, David. I think that's something probably we need to kind of get our medical director to look at. But from the point of view of patients, we know there's been some delays because of COVID in the timing of surgery. And I'm just wondering how you manage that if the expectations where people have had a pre-assessment maybe quite quickly, they're hopeful for surgery, and then obviously there are delays, and then do you have to re-see them? How does that actually work for you?
So our pre-assessments are valid for 18 weeks unless anything drastic changes. When we see our patients, they say to them, oh, you know, does this mean we're going to get our surgery? We're quite clear, and we say the pre-assessment is an anaesthetic suitability assessment to check. It's about safety. It's about making sure that you're managed in the safest possible way within the trust during your surgical pathway. And it's valid for up to 18 weeks, provided nothing else changes in your general health. We aim to have your surgery within that 18 weeks. However, if that isn't the case, we may need to call you to do an update for your pre-assessment or have some more blood tests, etc. We're aware as well that, you know, even if they're within that pathway, it's 12 weeks, it's 14 weeks, with a call out a week before, that's quite supportive to the patient. It reminds them of what's going on, etc., etc. So we do try to manage the expectations when they come for a pre-assessment, and we, you know, we're quite clear and say the surgeon's listed you for surgery, but to enable that to happen, we need to make sure that anaesthetically that you're prepared adequately.
I think having the staff, knowing we have the staff to the call outs a week before will make a huge difference, because if the pre-assessment was 16 weeks ago, a lot can happen in 4 months. So I think if we had the staff to do it every single day, I think that would help in terms of preventing cancellations as well, because a lot can change within 18 weeks.
Lovely, thank you very much.
So, Merrick.
Stephanie, Claire, thank you very much indeed for the presentation. I'm a non-executive here at Ashford and St Peter. I've been here nearly 6 years, and over the years in the committee, one subcommittee I chair, basically efficiency and performance through that is one of the key focuses, and it is just such a joy to hear what you've driven and the improvements that you've made, because we hear all the time that NHS's challenges and problems are maybe all about money. They're about many things, but actually, as with anything in life, it's about doing things better. And the transformation here that we're starting to see across the piece around DNA and wasted resources because of that, you know, what you're doing here is absolutely to the heart of that, and drives performance and efficiency massively. But of course, even more importantly than that, it's driving much better patient outcomes in terms of what actually happens to them. And also the part that you've touched on is their sense of security and wellness as they go through the process. So really just say thank you very much indeed. And so exciting to hear this, really fantastic.
Thank you very much. I mean, I think for us, the two things that have been able to allow us to do this is having our own unit. I mean, when I first started leading pre-assessment 8 years ago, we've been pushing under various service managers to get our own unit. And I think COVID was actually a blessing for us in a way, because we actually enabled us to be able to finally get our own space and be able to do it properly. And I think having anaesthetic consultant presence here, it makes a huge difference as well. And those are the two biggest changes for us that have made a huge difference and enabled us to provide this amazing service for our patients.
I think I just want to touch on a couple of other bits that we didn't mention actually as well, regarding the optimisation of patients and the other work that we're doing. I worked with Mark McGregor, one of our other anaesthetic colleagues, on the anemia pathway. We put that into play about 4 years ago. And it's made quite a big difference to the optimisation of our patients. We have a pathway whereby our patients can receive intravenous iron should they require so. And we've also put in place a patient group directive so that if our nurses identify anemia on a hema queue on the day for patients, we can actually supply them with iron tablets within the PGD. So that's really early optimisation for our patients. It's all done on the same day that they attend the department. So that was quite a large piece of work, but it's had quite a big impact on the optimisation of our patients. We're also working on a more robust diabetes pathway. There's much more awareness of the impact of diabetes now and how that can affect outcomes. So we're looking at a pathway for that. And there has been some pre-COVID, there has been funding secured for a Band 6 diabetic trained nurse to work within pre-assessment to try and support that, to support patients with diabetes who are coming for surgery, to aim for their optimisation and better outcomes. We've also got, we're also trying to do frailty assessments as well, to look at early referrals in the pathway. If we see a patient who we think are going to have a lot of post-operative needs and a lot of post-operative support to ensure they have a good outcome, that's hopefully going to be highlighted through the frailty assessment. So quite a lot more going on around, you know, the assessment and optimisation side.
Thank you. We've probably got time for, we've got 3 more questions on the things. We've probably just got time for those, so that's great. James.
Thank you, Chair. I just want to thank Steph and Claire. There's an amazing amount gone on. The contribution this is making to the theatre overall productivity piece that 4I's supported with, that programme's still ongoing, is immense. But you can't stress enough the change from pre-COVID to now. So there were periods when, Steph, where we were looking for rooms for a long time, but you were running out of, didn't have enough rooms. We were running out of rooms, waiting for a cancellation of a doctor so that we could then put a pre-assessment team in to actually run the clinic. So the change is extraordinary to what we have at the moment. So it is a really strong piece of work getting anaesthetist in on the day as well. But the one thing that I have, we've spoken about previously, Claire and Steph and I, is about that calling is really important, but also flagging where we think we need another call, because for some patients calling a week before isn't enough, and flagging and have the resource to then call the day before as well is part of where we need to be going with this. But thanks, guys. It's great to share that today. Thank you.
Thanks, James. Lord Andrew Mawson.
Oh, hello, Stephen Clare. Really good to hear that story. I'm a special advisor to the board, and I'm very interested in the interface between things and how lessons are learned. So I suppose I'd be sort of interested in what lessons you've learned that you think are applicable more widely to the hospital and the system, because often what we see the NHS doing, indeed some of us talked about earlier this morning, is they bring in McKinsey's or someone to write a very clever report that's very expensive about what you should do and how it might work. And of course, often these things don't work because the people writing it have no practical understanding of what's actually going on within the machinery, as you two clearly do. So I'm sort of interested in the detail of, if you could suggest some things, because here you have the board before you, to the hospital about how one creates more joined up behaviour like this more widely, both in the hospital and outside, what the lessons learned are. That would be good. And I'd also be interested in the interface with the technology, because again, there can be in the NHS this view that you spend a load of money on technology that then lands from Mars as though it's sort of going to work. And actually, the technology is a tool that interfaces between all that you're doing. So I'm just sort of interested to know how that technology is working, what you're learning from it, how the lessons you've learned might be shared more widely with the hospital system and the wider place. Just those interfaces.
So it was quite a big step for us to look at using a patient portal and getting that on board. We started using my pre-op, the patient portal, it's over 4 years ago now, wasn't it? And we were heavily involved at the trial stages with Ultramed when they were setting it up. And we had to think about what made it easy for patients, because that's the key thing. It's got to be easy and usable for patients. Yeah, So when we did that, we had iPads within the department, as well as facilities for patients to access it through the internet at home. And the big change with using the patient portal meant that we could triage patients, see them for 5 minutes, do the Robson swab, send them home, and then they could send information in for us. It was quite challenging to have the changeover within our staff, and also quite challenging to be able to work with IT to get the appropriate uploads onto our system, and with all the information governance and regulations and everything. So it was quite challenging and quite tiring to get that in place. But once it was actually in place and established, we did a survey and the patients really liked it. It reduced their time in the hospital, etc., etc. I think what helped us was, when we were initially setting it up, was seeing it in play at a couple of other trusts. Whilst it was in an early stage, we saw how other trusts were using it. And I think the key to making it successful was thinking about how it affected the patient and using it in a really practical way, so the patients only had to have one visit to the hospital. Because I think whatever changes we put in, the patient must be central to that. That is the purpose of what we do here. So you've got to be really clear about how it's going to benefit the patients and making it very, very usable for the patients.
Because even with the change to Cerner, unfortunately Cerner doesn't have a patient portal for their pre-assessment. So Steph and I were very adamant that we weren't prepared to move away from my pre-op, which meant we'd have to see all our patients face to face. So we're going to continue using my pre-op alongside Cerner when it comes live, because we can't we think it's a massive backward step to insist all our patients come and see us face to face. Having a patient portal makes life so much easier for the patients. So we're going to have to run the two systems, because at the moment Cerner isn't able to offer a patient portal for the pre-assessment documentation. And we thought that was vital it's such a massive step forward that we didn't want to get rid of that and have a massive step backwards for our patients.
And I think the same day service, whereby we're quite happy to see a patient on the same day as a surgeon lists it. I think that's about seeing pre-assessment as an integral part of the pathway rather than something that's separate. It's not separate. We all have to work together. And for me, my key driver is to make it better for the patient. What would I like as a patient? I'd like to be, listed for some surgery and have a pre-assessment done. No, I'm fit, I can have it done. I can be brought in at short notice. If I need to, if I needed to lose weight or get my blood pressure down or do anything else to make it easier to have the operation, I want to have the time to do that, not to be told a week before because I've waited months for my pre-assessment. It's all about having time to educate our patients, get their buy-in to what we're trying to achieve, to get the best outcomes. So I think it is looking at it as a joined up pathway almost. And I think it's about making the effort to link in with colleagues. It's not always the easiest thing. We may have to send lots of emails, lots of messages out on Aspire, lots of different things to get buy-in from everybody. But I think it's just about keeping the patient at the centre of it and keep driving towards what we think is works best.
And in terms of the change, I think communication has been vital for us in terms of the communication between us and also between various specialities. So we work very closely with the surgical leads, with the service managers, so that any lessons we learn, we feed on to others as well. And I think it's just about promoting what we're doing, which is why we'd emailed Suzanne. Because I think pre-assessment had a very low key presence for a while. I think people didn't realise what we were doing, and I thought it was time for us to sell ourselves and show what we're actually achieving, so people know what we're doing.
I think you've achieved that today, by the way.
Thank you.
So I'm going to give the last question now to Andrea.
Thank you. Well, it's a point really, but wow, what a transformation. It is true transformation, this. And I think, your passion absolutely shines through. And I know you've been on a journey with this from a few years ago, and to see the success that you've achieved is just wonderful, actually. And it comes out so loud and clear. My husband as well has just recently gone through your process, so I do know how slick it is over at Ashford. So congratulations, you got great feedback from that. But I suppose my reflection is, golly, this touches on so many different things, doesn't it? Not just from a patient experience perspective, but obviously from a workforce perspective, against the retention that you've seen, the efficiencies that you've clearly done, and actually the green agenda, dare I say it, because the patients are having to come back so many times and use transport, etc. So it probably needs to get written up in some respects, I suppose, is what I'm saying, actually, Steph. Maybe one of the journals we should look at that, because I think there's a real success story to shout out about here. And the end-to-end journey, I think, for me, is you do that phone call at pre-assessment, which obviously is clearly well received. And I know, obviously, then the patient has the surgery, and now we're doing a follow-up phone call, aren't we, following surgery? And that was picked up in the CQC. So it just goes to show this whole pathway is really shining through. It's brilliant. So last point is about complaints or PALs, I suppose. It'd be really good to see, the number of complaints or PALs that we got around pre-assessment before the changes were made, and as how that's made a difference. Hopefully it has shown a massive reduction, actually, because I know it was patients were getting fed up with having to move, here and there to do the different aspects of their pathway. So we need to shine a light on that, I think, again, to add into a journal write-up, but I do think we need to write it up, definitely. Thank you.
Thank you.
So look, thank you both very much. I mean, for me, this has been really inspiring, and I love staff stories and patient stories, actually. But for me, I think this is a story of outstanding leadership, with fixing it for our patients. And the other measure of leadership is always staff turnover. And I think you cracked that one. So, those two things together make it really thing. And I've put a knot in my hanky, so next time I come to Ashford, I'm going to come up and see you.
Please do. You'd be very welcome.
I know exactly where you are, but that beyond phlebotomy there. So I will come up and have a look. Not like a mystery shopper like Andrea, hopefully. Like us.
There's always a cup of tea at the ready for you. So you're welcome.
But look, thank you for sharing your story. I do think, you know, the things that have gone in my head, you know, I'm sure Simon has heard about the Cerner upload, and in due course, hopefully we can fix that. The ECG upload is a no-brainer, isn't it, if we can do that? And I think the MRSA, obviously, David will have a look at that. So, you know, I think, thank you ever so much for sharing your story. You're more than welcome to stay on for the rest of the board, but I know you've probably got better things to do.
Theatre just to get back to.
Exactly. So thank you for delivering for our patients. Thank you.
Thank you very much for listening to us. Thank you for your time.
Thanks for your time. Thank you.
Bye-bye.
Thank you, Claire.
Bye-bye.
Bye-bye.
Thank you.
They're always so powerful, these stories, aren't they? You know, and we get good, bad, and indifferent stories, you know, about from patients. Except, I mean, the patient story yesterday on ICB was horrific, absolutely horrific. And you know, it would be very easy to think, oh well, that was from another hospital, etc. But actually, I bet you that we've got similar stories here. But the staff story, that was an inspiring staff story. I don't know if anybody else wants to reflect on it.
I do think writing it up and in capturing these stories and sharing the principles, what was learnt, what were the challenges, etc., because these micro stories will be issues everywhere. It's not just for you. I think capturing these things, and also people who are real in the system saying, well, it can be done, we did it, and this is what it looks like, is quite an important message, really.
I mean, getting them a tablet, Andrea, with the, you know, the our patient feedback stuff on, you know, the trust-wide one, I think would be really good, because it sounds like we're going to, you know, we'd get some numbers through, because, you know, we always complain, don't we? We don't get the numbers to be statistically significant.
Yeah, that's right. In fact, I forgot to mention that. I wondered if they had a kiosk in their area. We need to check that out, actually. But you know, have the kiosk and the tablets, just
because it sounded to
tap.
me like they were doing their own.
Yeah. So yeah, absolutely. We'll jump on that.
David.
Yeah, no, I mean, it's really fantastic. I suppose my reflection is what a difference a phone call makes, doesn't it? You know, a short phone call at both ends of the pathway, that is what it's about. And what we see in lots of our issues, it's all about communication, and it doesn't take a long time just to let people know you're there and you can contact if there's a problem. And I think that's the key thing, and we need to make sure we look at this in other areas as well. Discharge from the ward, for example, to check they're okay, and we have tried that previously. But people got to make sure they understand the value of these things. That it does take some time, but it's so valuable in helping other things. So I think a fantastic story, really fantastic.
Thanks, David. Fran?
Just really agree with what everybody else has said. You know, really great story. The personal approach is what I think, you know, either by phone call or by person is very powerful. And I just wanted to sort of reinforce what Andrea was saying, really, about being able to demonstrate the impact and the outcomes that have changed, and maybe giving a little bit of attention, not just about complaints and PALs, but some of the, you know, as you say, the lack of, or the reduction of cancelled on the same day surgery, things like that would be really powerful. And, you know, there's lots of awards coming up, aren't there? And we really need to think, I think, always about trying to put things like this in, because they probably seem quite simple to them and it's their sort of day job, but actually it's that whole package and the impact that it's had, I think, is really worth writing up. So that's all I wanted to say. Thank you.
Yeah, thanks. Thank you, Fran. And last one, Chris, before we move on, Chris Ketley.
Yeah, I thought that was so inspirational, wasn't it? And yeah, I mean, I agree with what everyone said here. Andrew, just made me think, you know, what's possible when you have a unit like that working together end to end, making, you know, all with a focus on the patient. And you sort of say, well, if you took that model and magnified it across the hospital, I wonder what would happen. or can it be? Is that possible? I don't know. And on a smaller scale, Andrew, I was just wondering, just picking up on Andy's point, is there any way we can sort of really get them to get to grips with the friends and family, you know, and that whole thing, and maybe, you know, see what figures we get out of it, and then what they then actually have done, and duplicate it elsewhere. It could be an important learning curve for us.
Yeah, definitely. As soon as we've finished here at board, I'll be on to that and making some phone calls and
Yeah.
stuff. So yeah, we'd need to get something quick in there. I agree.
Super.
Good. Really good.
Okay, good. Great start to the open board, I think, and I hope all our visitors enjoyed that too, because, you know, pre-op does affect our patients so much, doesn't it? Okay, so any apologies, Liz, for this meeting?
No apologies received for this meeting.
Okay, so just formally, I'd just like to welcome David to the meeting in his new hat as acting chief executive, and to thank him sincerely for taking on this role. I think, you know, we know you'll do a great job, David, and thank you so much for stepping up. And also welcome to John Murray from Deloitte, who's observing and will feed back in due course as part of their well-led review. So we're now going to move on then to the draft minutes, and this is the minutes of the open board on the 2nd of December, and there were many pages actually. So has anybody got any points on them rather than flog through page by page? Jane?
Picking up the story that we have at the last board, which Beth brought to us. There's quite a number of actions there. I just wonder where we're picking those up. There were some suggestions from Beth about how we might improve the experience for patients, and I'm just wondering how we're driving that forward.
Good question, because they're not actually picked up on the action log, are they? Andrea?
Yeah, there's different forms we can take that through. The first one, I think, is probably our patient experience monitoring group, actually, which should be key. So we do need to, you're right, there were several things that came out of that discussion, wasn't there, that that we haven't taken forward, but we can.
Yeah, and I know that from my discussions, because I'm doing one-to-ones with governors at the moment, they were kind of, they'd zeroed in on that Beth would be a good person to kind of get, you know, give us some advice on various things, and I think, you know, important we do follow through on that.
Yeah, absolutely. Totally agree.
Thank you, Jane. Any other points on the minutes? No? Can I take that as approval then, please? Those minutes. Yeah, good job on them, Liz. Thank you. I'm just can only go at the speed my finger goes on the touch screen to get through the various pages here. Right, so we now move on to the action log, and I think we've got on the agenda. Where are we covering on the agenda? The walkabout. I know we've had to suspend it, Andrea, due to IPC, but it's saying due date on the agenda. What's going to be the update on that, do you think?
Well, golly, I mean, it's sort of it's under review, isn't it? I suppose is all I could say. I mean, we've still got restricted visiting in place. Obviously, we tightened up those guidelines at the start of this third wave. So I think this month, I think it's still a bit precarious, really, the community incidents. So just to continue review, and I think I did say hopefully we can review it in March and see if we can reinstate it. But obviously, David will have as Dipsy will have a view on that.
I think it's important to be under review, isn't it? We've got to be safe, though. David?
Yeah, I mean, I just backing up Andrea, really, yeah. It does need to be under review, but, you know, the nosocomial transmission rate in the hospital is just a signal that we're certainly not at that place when we can release it at this moment. And if you look at the rates in the hospital of COVID, they've kind of plateaued around about the 50 patient mark. So it's a different shape than we've seen before as well. So yeah, we'll keep it under review, but we're not there yet.
No, and I know colleagues, non-executive colleagues, are keen to get out there, but you know, the patient safety has to be our number one priority here. And certainly from my perspective, I am only going on wards when I absolutely have a thing to do, and actually that is pressure ulcer certificates. Just from looking on morale, presenting those, that's the only reason I'm actually going on wards at the moment. Okay, thank you for that. I don't think there were any others that are not complete or closed. So we'll move on to the report. So just to remind colleagues for this and also for our visitors, at the moment we're trying to release time for our executives and keep these meetings short because of the pressure on the hospital and the pressure particularly caused by Omicron and the numbers coming through and beds, etc. So what we're going to do is we'll take reports as read and we'll ask authors to bring to our attention 2 or 3 things that they want to bring to our attention particularly. But obviously all board members still absolutely are encouraged to raise any issues or questions they have on a report. So we're just not going through reports on a blow by blow. We're taking them as read, but colleagues are absolutely free to ask questions. So my report, which I did cut down this time, no pictures today. But I think it's important. There's some things to say that are important. The first thing is, again, to record our thanks as a board to the team ASPH, because my goodness, if anything, I think James said it earlier on the closed board, pressure now is more than it ever was. And I think there's a danger with the media, etc., to think, well, it's all over now, and indeed politicians, it's all over now. But actually, for us, we're still in the eye of the storm. When we're in the eye of the storm because we've got a combination of factors now, whereas the first wave, it was all focus on one thing and everything else, was put to one side. And that, in a sense, although it was very, very tough, was easier. But now our staff, 2 years on, exhausted physically and mentally, are coping with a multitude of issues. And we're trying to get waiting lists back and everything else. At the same time, there's a pandemic and a lot of our staff have got young children. We know that the rate of Omicron in young children at the moment is very high. So either they're looking after children or they're getting it themselves from their children. So it's a really big point of pressure. But I just want to say on behalf of the whole board, a huge thank you to staff because they are carrying on and they're putting their heads down and getting on with it. When David comes to do his report, we are going to spend a little bit of time talking about the Cqc report, and clearly we'll do that in detail at the next board meeting when we've got the action plan, etc. To look at, but we have had a Cqc report, and I don't want to steal his thunder too much, but there's some good stuff in there and there's some stuff to fix, as you would always think, and we will come back to that. The other thing, clearly, we just to report formally that we have offered the post of Chief Executive. We're not yet through the HR processes, are we, Louise? So we've still got a few things to tie off. We will make a formal external announcement as soon as we possibly can, but we're not yet in a position to do that. But as I said earlier, the trust is in absolutely safe hands under David's leadership in the meantime. We are also, yesterday, the Governor's Selection Panel sat for a non-executive director who eventually will take over from Merrick. This is for the post of Associate Non-Executive Director to shadow Merrick until Merrick finishes his 6-year time span in July. We have got a recommendation. That recommendation will go to Governor's Nominations Committee and then for final ratification at the Council of Governors. But I have to say, we had a strong 4-person list and there was some good debate around that. And I think we've got a good candidate to go forward. And I also want to thank and congratulate Shirley Holmes, our new lead governor. She was on that panel yesterday, performed really, really well for us. Really good leadership shown there. Thank you. So thank you, Shirley. We're looking forward to working with you. I won't go into the Anne Eden meeting, but just to say that we really did, with the Royal Surrey, and that's really important, put our best feet forward in terms of presenting our plans around Ashford Hospital to the regional director of the NHS. And I think, as I said on the system board yesterday, actually, it's a good model going forward to demonstrate how well we're working together. So that was very good. And yes, finally, that final paragraph, you know, to formally put on record here, Suzanne has taken up her new post in Wales. And, you know, to say, I've said it many times over the last couple of weeks, but to say a formal huge thank you to Suzanne for not just the 7 years as chief executive, but 11 years of service to Ashford and St Peter's, where she showed outstanding and innovative leadership. And I know she will do really well in Cardiff and the Vale, and we wish her well. So I will stop there. I'm happy to take any questions. Otherwise, we'll move on to David's report. Good. Okay. So, David, the floor is yours, and if you could perhaps kick off with something around the CQC report, because obviously it is published. It's in the public domain.
Yes, I've woven it into the report a little bit, but it's probably best that we spend a bit of time, and Andrea will also have some things to add. So, as you know, we had an unannounced CQC visit to the hospital recently, and this was triggered by two things. They were coming to do a focused inspection in surgery because they'd received quite a lot of whistleblowing from the team in surgery, and we had put quite a lot of work in and action to try and understand where that was coming from and how we could address that. But the volume was still coming, so they were coming in to have a look at that, and also they came in to inspect our discharge processes. And I think the first thing to say is how fantastic the team responded to this unannounced CQC visit. I mean, we have to put this in the context of the pandemic. Operationally, incredibly busy, both through COVID and also through the emergency pathway and through all the restoration and elective work. But the team were absolutely fantastic, and they commented how the team were open and transparent and willing to discuss and share. And I particularly, and I know Andrea was as well, were particularly proud of the triumvirate teams as they proudly showed their services within the organisation. So there's a huge amount of good. They saw the patients were cared for, looked after, they were clean, they were well fed. There was lots of really good things in the report. There are a few things where we need to improve, and some of those are relatively straightforward to improve, and we should have paid attention to them. And that is things like the infrastructure in theatres. So some of the fabric in theatres was not as good as it should be, and that does carry an infection control risk. And in fact, before they came in, myself and Andrea had been discussing about actually the flow within theatre, and this goes back to a point that Andrew Mawson raises about making sure we've got the flow and the processes in place to for infection control and make sure they're absolutely correct. So there is some work that we need to do in there, but clearly the thing that came across, and I think that you'll see in my report and after the summary, is reflecting on what they found on both sites when they went and talked to the team. And in fact, they came back and they said, although they knew about the volume of the feedback through the CQC from anonymous whistleblowing, they found, particularly at Ashford, they found the team really proud and happy. They changed so much during the pandemic, and they were very proud of what they developed at Ashford and the new infrastructure and how they were delivering care. And they didn't detect a huge amount of unhappiness in that environment there. They did, however, detect more on the St Peter's side, and also they were fed back that that some of the senior clinicians didn't feel that we'd listened to them as much as we should, And I think we just need to reflect on that and just reflect that this has been an absolutely dramatic time of change for the clinical teams. And looking back and see what's happened over the last 2 years with the radical change in services and the delivery model throughout our organisation, with us moving outpatients out of the hospital, elective care all over to Ashford, and that has great impact on the staff, and we know that is the right thing to do in terms of patient delivery, but we just have to reflect and see if there's any way that we could have done that better. The other thing we did in terms of the feedback, in fact, after they'd visited and the report was being drafted, we did have a discussion, myself, Andrew and Suzanne, with Ted Baker and the team from there. And actually, Ted Baker was really open, and we made the point that we absolutely welcome the CQC in coming and reviewing our hospital and actually helping us improve things the way we need. And we had a really good discussion about what we found, how it felt, and how they could help us in more way. And actually, after they sent us the report, in fact, we had it was just myself, Andrew, and Suzanne, without any of the other teams from other hospitals, with Ted Baker. And again, that was a really good visit. And what he said to us, he said, actually, you are doing really well. As an organisation, you're doing really well. You've maintained your good rating overall. There are clearly areas where we need to concentrate on improve. And actually, he said you should take this as very helpful, which we do. And I think the important thing to do is to reflect what the CQC are taking us. And it is, as you can see in my report, this is all about people. This whole pandemic has shown that it is about people. It's about our patients and our workforce. And our workforce have been absolutely incredible during this time. And they've worked amazingly hard. They've had to adapt. They've had to adjust. And they've had to meet disappointment when we think that we're reaching the end of the pandemic. Unfortunately, that doesn't seem to be the case when another wave comes along. And actually, there are other conflicting demands on their time, such as the winter pressures through the emergency pathway and through the recovery. So there's an enormous amount of pressure on the staff, and there's an enormous amount of pressure on patients who have had treatments delayed during this time and are clearly concerned and worried about that care. So I'm hoping you'll see that in the summary I have tried to reflect that into our triangulation of results. I think the conclusion that I came to when I looked at the triangulation between things was that we still have to do some work on our key performance indicators to make it clear how we reach the risk levels that we've got in the various strategic objectives and our concerns there. But I think the CQC visit is a great opportunity for us just taking stock. But it's about the demands on the workforce, the changes in the system, and actually those effects therefore on the patients. And Andrew, do you want to add what you think I might have missed out in the CQC report?
No, I thought that was
there's a lot more work we need to do on that, so I've just given you a thumb scale. So
I thought that was a really, really good summary. I think the key bit for me really is that, and particularly when Ted Baker, the Chief Inspector for the CQC, stated that, Ashford and St Peter is regarded as it still maintains its good rating, and there's lots for us to be proud of within the report, and we are. And I think we actually went up from requires improvement to safe to good in 2 of the domains and went down only in 1. So we need to put this in context. But I think in light of the pandemic and particularly the last 2 years, for us to go up from requires improvement to good for safe, both in medicine and surgery in Ashford, is it's commendable actually. And I think it's with all the challenges that the staff have had, to actually improve on the safety during this time is exceptional. I'm really proud, of what we've done. And again, that's down to the work that the teams have done around the safety culture, obviously the quality team, what we've done through, the QCC, the quality committee as well with our quality priorities. It's all come together, and it clearly was evident when they went round and looked at the evidence and spoke to staff as well. So I'm really proud of that. I think because a lot of other hospitals have gone down, I think we need to put this into perspective. And so to maintain our good rating, but also to go up more than down and particularly in the safe is exceptional. So that's all I'd like to say. Well, obviously, we'll produce an action plan. You're absolutely right, which will feed into the next trust board.
Yeah. Mossine.
Thank you, David and Andrea. I know that this has had a lot of airtime at Quality Committee, but as a formal board, I'd like to just make 4 points. Whilst a lot of it is positive and it's very good to read, obviously there's some quite concerning issues, and to have St. Peter's downgraded to requires improvement. I wanted to know how it affected staff morale at St. Peter's, given all the issues we've already got with exhausted, worn out staff. And have we spoken to the theatre staff, and what's their response about how they've now seen it come out in black and white? I, of course, look forward to the management's response to Cqc report, because, of course, I don't think we as the full board has seen that. And I wanted an issue relating, to the patient story, the staff story this morning. There was a staff team you felt really empowered to make change and to raise issues when it wasn't good enough. And yet we don't seem to have that empowerment in the theatre staff when they saw walls and issues around building maintenance. So how do we empower all staff to actually take charge of their own areas? And if something's got holes in walls, how do we sort that? So just some reflections and some requests for the detail, David, later possibly.
Yeah. Shall I come on to that? I mean, there's a lot in your questions, so point out if I miss anything out. So how was the team morale? Well, as I said in my opening thing, the leadership team in surgery and medicine, I mean, I was so proud of them. I mean, in terms of the fact that they were together as a triumvirate, and they really wanted to show their services and meet the team. So they were disappointed, Marcy, actually, in the response. So and we spent quite a bit of time to them, particularly after a conversation with Ted Baker, saying, actually, you've done really well. It's just that there's some other things that we need to spend a bit of time on. So that did need some managing, because they've worked so hard. They've done so many unbelievable things. They've constituted changes which would have taken us years to do before. And so we did need to support them a bit. They were disappointed, Marcin, but actually, as you say, there's a lot in the report. There's just some things that we need to concentrate on. I think your point about empowerment, and I suppose that the one that's gone down is the well-led in surgery at St Peter's, and I suppose that is about empowerment and understanding. Well-led is everyone taking their own responsibility and making change. And I think we have got to do some work with the whole of the team, saying actually, this isn't just following some instructions from some leadership group. This is actually us all understanding that. And I think that what I thought, and myself and Andrea, we've walked around the theatres and everything, it is quite easy to get sometimes, I think, a little bit complacent about things, that you tolerate it. And therefore, I think that's what we recognise from that. And I suppose that's what we learned from the pandemic, isn't it? We've learned that pre-pandemic, healthcare systems generally were complacent about infection control to a certain extent. And what we've realised is how important it is. And actually, if you look at the quality report, we looked at that. There's some areas where we can see that actually places where we had some infection things, the things that we put in place have solved those other infection control problems. And actually, it's highlighted that there's other areas that we need to do to work. So I do think in terms of, you're right about the engagement and how we talk to that team and help that team come forward. We've done quite a lot over quite a period of time when this whistleblowing came across. But I think we do have to. There's a big piece of work to do, and again, in the 4 things that I thought was important that I did during this interim period, one of them is that, and it is understanding how we do that and how we give Louise's team the capacity to be able to do it, because it's all about workforce and people. Everything's about workforce and people. Andrew, did you want to add anything into Marcin? Oh, I missed a bit there.
No, I think you've covered it all very well. Thanks, David. Thanks.
I hear you, Andy.
So, Andrew?
Yeah, no, thanks for that, David. I mean, having observed over the last couple of years what's been going on in the hospital and all this, I mean, this is an extraordinary thing this group of people have lived through. Maybe the only time in their career they will live through such a set of events, which was unique for everyone, just to put it in perspective a bit, because one's watched the major changes you've all had to make, which have been extraordinary, and they were right at the eye of the storm. So one's very aware of that. The other thing I wondered about, David, was I mean, these are all scientists, and we're developing, aren't we, with the Science Summer School with Brian Cox and Brooklands, actually, this whole thing about the links between science and health and the Bourne Academy, all these things. I am conscious myself, I've had very little engagement with any of these people, and I did wonder whether we should open up some of those things, because I'm also conscious in the debate in the House of Lords around a lot of this stuff with the new health and care bill. It was senior surgeons, actually, and it's the first time I've really heard this, that were beginning to argue the case for the social determinants of health, actually. And it was, I mean, you've been, David, way ahead of the case on this than many I've heard before, but actually it's quite interesting. There is major change going on here, where very senior surgeons in hospitals are saying, well, it's not all about hospitals, actually. It's about these wider relationships. And I just wonder, it's just a thought, David, whether, because you were involved with this, as you know, whether we should just join the dots a bit around that, whether actually the issue is also an opportunity to open up some of these relationships, because no one realizes they are doctors, but they're also scientists, actually. And that future workforce and all of that is an important linkage.
Yeah, no, I think it's a really good point. I mean, I think the hospital is full of people with science degrees, but medicine's an art as well, and all these people are emotional human beings, and I think they've done it. I think you're right, Andrew. They've done extraordinary things, but sometimes the change has fallen in certain places more than others, and I think actually surgery, theatres, anaesthetics, and all the staff involved in there have had to change and be more flexible. So they've been redeployed to intensive care from their theatres. They've had their work shifted over to another hospital, and so on. So I think what we're going to use this, Andrew, I think is reflection about actually the change, and could we have managed our articulation and our discussion with them better. But I think you're absolutely right that we need to bring them in this wider conversation about the community and what drives community health and what their role is in doing that, and making them, have more involvement outside the walls of the hospital. I think that is a really good point, Andrew.
Thank you. So, thank you for doing that on the CQC. I think that was really important, given it's been published, and this is our open board meeting. We know that obviously there are timescales involved with when we have to get back to the CQC with the plan. I think it's important that we see that plan as a board circulated, so that we can have a look at that and then bring back that plan and if you like, as Marcin rightly says, the management response to the CQC, the formal one, to the next board, please. So David, what else from your report would you like to highlight?
Yeah, I mean, I suppose as you know, as everyone's used to this, but I think part one, I think I've covered it. I think if you look through that and you see the triangulation of the risks and things, and I've tried to add a bit more in about the KPIs, so there's just more information in one place. And I know we'll be touching on that as we go further on the board with the sub-board committees being represented here. I suppose in part two, if I just turn to part two, if that's all right, Andy, if we've finished with part one, I suppose I would highlight the main effort, and I think I think Andrew will recognise that this is part of our articulation of actually that the hospitals, we need to be looking after people within the hospital, but we need to make sure that actually we support people, we meet their needs to get them home where they wish to be with their loved ones at an early time, and that's part of this whole thing that we're trying to do, change the culture of the emergency pathway. So the main effort I think is important, and it just helps us discuss that with the staff. I mean, the health and wellbeing hub being opened, I think Louise's team did an absolutely amazing job on that, and the staff are really enjoying that, and the fact that we're going to develop this over at Ashford is incredibly important as well. The Walton Care Unit, I just wanted to mention that. I mean, Andrew and her team, this was absolutely a phenomenal change over a short period of time in mobilising a team with a different operating model to cope with the huge demands that we had in the hospital, and it's extraordinary that the team did brought that in place. Two things at Ashford: the development of the pharmacy service. I think that's a great improvement, and it helps with the increased capacity and workload that's going through pharmacy. So that's a brilliant initiative. And James and Megan were involved in the blood bank, and this was in response to making sure we had a rapid response to the massive hemorrhaging policy, and we looked at some SIs, and we looked to see how we could improve that. And actually, we had funding for an anonymous donor for this extraordinarily quick bike that Andy Hyatt is enjoying driving back and forth to Ashford. But it's a great step forward there. Surrey Safe Care, Simon is pushing forward on Surrey Safe Care. It's a massive initiative. It's taken a huge amount of work, and we've been doing it together with Royal Surrey. And the Veterans Aware Trust accreditation, which I know is dear to Andy's heart. I think we're all very proud of that. And then Andy, you touched on a couple of visits. You touched on Anne Eden's visit, which I think was absolutely a fantastic milestone. That we were sitting in a room in Ashford with the chief exec, the medical director, and their transformation leads, with our team as well, talking to Anne Eden about how we can work together to provide elective services, a regional centre at Ashford for our community and the wider community. And I think that was a fantastic walk together, but it was also testament to all the work that had been done by the teams over the 2 or 3 years before. And James and Tom and Simon, you know, the transformation you've been doing at Ashford during the pandemic has been quite extraordinary. And that's given us this opportunity, which we now need to take. So that's a really, I think, a fundamental point, visit. And the other was the visit from Ian Smith, who's the chairman of Surrey Heartlands. And again, he walked around, he was really impressed. He had great discussions with the team. And he sees that we are an organisation who want to collaborate across the system, across the wider system, to help our communities. And I think they were two really important visits that went really well. Thank you.
Thank you, David. And just to build on that Anne Eden visit, I mean, I was asked to speak on that to the ICB, the Integrated Care Board, yesterday, actually, because they see the impact of that visit as well. And I know that Anne Eden, on her regional call with all the chief executives last week, I think it was just saying how impressed she was with it. So, you know, we did make a big impact. But for me, it was the impact of two organisations just being so clearly joined up, thanks to, as you rightly say, David, all the work that has gone on over a couple of years now, isn't it? Into, well, more, 3 years probably on Surrey Safe Care, building from the ground up, so that it wasn't a false thing at all. It was a natural presentation. So really good work. So look, questions on any of David's reports? think, David, in terms of part one, you know, it is clear the risks that we're facing at the moment, and having sat in on some of the subcommittees last week, I think all the subcommittees were taking the risks that we are facing really seriously and looking at the KPIs. And when you look at the KPIs, it's clearly, it is a time of great risk for us. But they're not risks that are not being managed, which I think from a board perspective is really, really important, that we've got that assurance that these risks are being managed to the extent that some of them can be. Clearly with, you know, the workings of the pandemic outside the hospital, we can't do much about. But you know, we've heard about IPC and addressing the issues inside. And these are clearly really important issues for our patients as well. Keeping loved ones safe when they're in there, and also the downside, of course, of reduced visiting, which is a big burden for people in the community, which we have to keep cognizant of and strike the right balance, don't we?
Yeah, and I think you're right, and I probably didn't pull that out in the report because of the CQC, but James mentioned it in the closed board. And it's the impact of the Omicron variant is, I mean, all the waves have been so different, and this third wave it hasn't led to the intensive care utilisation, but the numbers have been huge in the community. The transmission is, you know, 5 or 10 times more than that, and what that's led to is nosocomial spread within our organisation and outside the organisation had the risk. And also the operational issues in terms of closing beds because they're quarantined, and also staff sickness. So it is, plus we've got the winter pressures. So that is, it is about, you know, that is something that has been very, very different in this last wave with Omicron, and it's put a great deal of strain on the workforce.
Thanks, David. So if there are no other questions for David, I'm going to move on. We're about that time anyway. So Andrea, Louise.
Right. Sorry. I was just quickly reading through the paper just to see whether it was referenced, but I thought I should probably mention it anyway. Obviously, when our people committee met last week, one of the key risks that we were identifying was the potential for workforce supply following the termination of contracts of people who hadn't had 2 vaccines. So the vaccine is a condition of deployment work. And we were updating the people committee on Friday in terms of the work that we'd done to reduce the number of unknown records from 1,500 at one point down to less than 100, so that we were in a better position to identify where those risks might be. Obviously, we weren't aware that the government was going to rethink the policy over the weekend, and that's obviously what happened. And fairly unacceptable the way we found out after all of that work that we put in. But it was revealed via the media that the government was planning to do a review of that, and obviously we're still waiting for that to go through the parliamentary process. But we have been instructed by NHS Improvement to not instigate the process that we would have been putting in place, which was a process of termination of contracts, issue of notice of contracts from tomorrow onwards. So obviously, the first thing to say is, you know, pleased that the risk around future workforce supply is not going to be affected by that. There continues to be a push from an organisational point of view to encourage people to have the vaccine, and the reason around the importance of doing that, and we will continue to have those conversations and educate our colleagues around the benefits of that and explore with them the issues that they're concerned about. But I guess it was important just to note formally that that's now not the risk that we thought it was on Friday.
Yeah, thank you, Louise. That's really important, actually. And you're right to highlight that it is not the right way to find out about it either. I think that we all feel that. But we will deal with that. And of course, I think it's really important that you say that, you know, we are still seeking to persuade colleagues, those who haven't had the vaccine, to have it, because again, it comes back to our patients and keeping them safe. So thank you for that, Louise. So we're going to move on now to the quality report. So Jane first, before we come on to Andrea. What did the quality committee look at in particular that you'd like to draw the board's attention to?
Thank you. So we received this report for approval last week. It's quite a detailed report, you will see. Some of the areas we're particularly focused on is we're still not where we need to be from a patient feedback point of view, and we have talked about that a little bit earlier, particularly with our staff story. And so we know there's a lot of effort going into that, but our target of 20%, we're not really close to that yet. And our complaints performance had dipped. So the committee asked that there was a focus on that and assurance that that would improve for the next meeting. We were really pleased with the update on the healing arts, particularly on, I know Marcine had fed back about the Nature Works for Health, and just how well that had been received and just how positive it was for making the environment much more pleasant for patients. So we were really pleased to see that was in place. We had some discussion about the Antimicrobial Stewardship review, and David picked up that actually there was some disappointing information there which needs some clear focus, which I'm sure Andrew will talk to. Our medical examiner continues to do some great work, although there is some delay in doing some of the structured reviews. Finally, we did have a very small section in the report on maternity, but I wanted to assure the board that we had a full report from the head of midwifery, which the quality committee did look at in detail, which had a lot more detail around workforce, had a lot more detail around the serious incidents within maternity, just to assure the board that we had that level of scrutiny following the Ockenden requirements. That you just see there's a very brief summary in this report, but we did have a separate full report that we had and approved at the committee. Thank you.
Thank you, Jane. Andrea.
Okay, obviously take the report as read, and just to pull out some key aspects, just to complement what Jane has just said. So, starting with patient experience, I think you will see that our performance around the turnaround of complaints has clearly dipped, and it's twofold as to why that is the case. We've got significant sickness within the complaints team. It's not job related, just to harness that. It's due to other aspects, but there's long-term sickness that's just happened in that team, or has in the last few months. So we are putting in extra support to that team. We're getting some people seconded in to help with them, because we're generating a backlog in complaints. We need to solve that. Obviously, given assurance to the committee that we will do that, and obviously we'll report through the committee on that. So we should start to see an improvement. And then the feedback. There's a quality improvement. We've wrapped it around a quality improvement project around the patient feedback now. So we should start to see improvements in that, but it's not where it needs to be. From an infection prevention control perspective, it's a bit of a mixed bag, actually. So there's some great performance on bacteremias, actually. I mean, we're meeting most of the targets, and we've set really strict targets around, from our quality priority perspective for this last year, around our bacteremias. And we're making fantastic progress around that. And I think that's, testament and down to our IPC strategy, our refreshed IPC strategy that we reinvigorated and are applying to since the start of the pandemic. It's not just about COVID, but it's about all infections. But you'll see in the report, I mean, this data is from November and December, and this is clearly the start of us going into the third wave. So this is, you can see from a COVID perspective, we were starting to see an increase in cases, which then you can clearly see as outbreaks that have occurred as a consequence because of our increase in numbers in the organisation being admitted, and then transmission. So since November, it's been continuous comms reiterating to the staff about the practice, which is what we did during the last wave as well, about the good IPC practices, hand washing being pivotal, but also people maintaining their distance. We've restricted visiting as a consequence to reduce the footfall. and obviously cleaning as well being really key, and ventilation. So making sure that the HEPA filters in the clinical areas are switched on, and where possible opening windows as well. The antimicrobial stewardship, which we just mentioned, actually is again it's been a challenge. They've changed the focus on the audit. You'll see that from the report, and that's produced a action plan for us, which we're now going to monitor through the divisions to see compliance against that. So hopefully we'll start to see improvement. But David might want to speak about that in a minute. And then from a surgical site perspective, again, we've seen some good progress there. The bit I'd like to pull out really is around cesarean sections, which has for many years has been real issue for us. Not really being able to crack that one, but we have seen a real improvement in that, I'm delighted to say, and it's down to all the work that the teams have done. And clearly our surveillance is getting much better on the SSI piece as well. Sepsis is work in progress with sepsis, I have to say, and it's around about the compliance of the bundles, and we did speak about this quite a bit at the committee as well. There has been some improvements, you'll see, but it's not where it needs to be, and that improvement programme is being fed through the ED, the A&E department. And then the last two bits I just wanted to pull on is from a safety perspective, we've already talked about in closed board actually about the harms, and the bit that really has spiked is around pressure damage. We're seeing far more pressure damage coming in from the community, but again, due to the demands and pressures within the organisation, we're seeing damage as well within some of the ward areas, and we've got a harms-free care improvement programme wrapped around that. The falls perspective, we had some really strict set some really strict trajectories around the falls. And so we've had a few more falls again in this reporting period than we would have wanted. Again, it's indicative of the pressures that we've been seeing, but repeated falls actually is still is still a good news story around that, and it's all around doing the blood pressures and all of the measures that need to be done in order to ensure falls don't happen. Maternity I won't cover because Jane's already covered that off, and I think we did cover that in depth during the Quality of Care Committee. But healing arts I think is worthy of note. We've reinvigorated that programme, and down to Marcine's energy and passion as well. And let's thank Marcine for all the hard work she's doing with us as a non-exec director on this. But the Nature and Health pictures have now gone up into the ACU and UTC, and if you haven't seen them, please do, if you have an opportunity, go and see them, because they are absolutely fabulous. And the patients, as soon as they were put up, the patients were overjoyed and just saying how calmer they felt as a consequence. It's woodland scenes, it got bluebells, it's beautiful, all lit up. So we're very chuffed about that. And we've got a meeting after open board today to talk about the Time Garden, which is another new initiative that we're bringing in, and to get the updates on the timelines around that. And that's work in progress at the moment. So again, another exciting initiative. And the last bit around the healing arts is that we've set off our Making a Perfect ward. So wards were asked to put bids in around where they could make an improvement in healing arts, and we went through that. We had our panel day before yesterday and went through who was successful with that. So it's all good. So I'll leave it at that. And I think I'm happy to take any questions. And David might want. David, did you want to come in on any of those bits?
I mean, I think you've mentioned everything. I mean, I think just to emphasise what you said about surgical site infections. I mean, our surveillance and our checking the patients, I think, is really good now, and therefore we are seeing some slightly higher rates in some of the orthopaedic procedures. But I'm happy we're surveilling right, and it's now a question of making sure we drive those incidents down. I think the new audit on the antimicrobials, I think, is a really good audit. Actually, I think it does cover the whole thing, and I think the action plan was around that. But I just wondered, Andrea, whether we get the medication safety team to start playing a role in that as well, because they've done such good work, and maybe giving them a part to play in this would be helpful. That's all I have to say.
Thanks, David. James.
Thanks, Chairman. Thanks, Andrea. It was really good. There was a really good part in the paper about the children and young persons annual survey. and the results from that. And there was some really rich information in there, but we didn't allude to how we're taking that forward or any plans around that. Do you know what's up? Because it'd be really important that we don't lose that rich information, isn't it?
Yeah, no, that's right. So that'll feed through the committee and obviously feed through the divisional reports that come to committee. But you are right, some great stuff in there, and obviously areas for improvement. But that's how that will all be monitored.
Thanks. Marcin.
Thank you, James. I was going to ask that question. My other question was actually just a recommendation for you to consider, Andrea, and David's medical director going forward, which is, could we not have an assurance summary on each of these indicators? It's a very big report, and it's lots of rich material. But if we can actually start to pull the data and the mitigations together, it would provide assurance, as we do in the performance report. I feel it would be better in terms of a board's ability to take a more helicopter view around assurance on the quality agenda. And I think it will also be helpful for the executive to actually focus on areas. So I would just recommend that. And can I also say, although healing arts was included in the quality report, we have agreed now at Modern Healthcare that it will move to Modern Healthcare, as we're trying to institutionalize healing arts. It's not just about patient experience, it's about outcomes. And besides, I'm excited about the Time Garden, and of course, if you haven't seen the Nature and Health and the reaction of the nurses actually about the environment, is about the research about the patient outcome, and that's where we're focusing this. So I'm really excited that we're now getting this across the board into the whole heartbeat of the organization. Thank you.
Thanks, Marcin. Any other questions for Andrea? I got one, Andrea. I asked at closed board, but I think, I know the governors and members of the public would be very interested. The pressure ulcers, clearly, it's, as you said, it is an issue. When I go and present the certificates, it's always the same teams, or very often the same teams that get them, and it's about, perhaps just for the governors and the members of the public, how we're going to embed that learning from the places that have really good, or the wards that are constantly good on that side, into the others.
Yes, thanks, Andy. So, I mean, as we spoke in closed board, I mean, we've got a fantastic harms-free care team that we set up in the organisation about just before the pandemic actually hit. Really good timing for us. Has brought all of the harms together. And Sue Harris is our harms-free care consultant who has a specialism in tissue viability. And I think that team have worked collectively across the whole harms piece. So not just looking in silos, but collectively to improve the harms within the ward areas. So there's that first point, I think, and we're on a journey obviously with that. But the second point to be able to harness that learning is around our harms-free care champions that we have nominated within our ward areas as well. And for them, through Sue's leadership as the nurse consultant, is bringing those champions together to look at the issues, but also to harness that learning that they then can take back to their ward areas. And again, that's all work in progress, but and we're on a journey, but really good. And then the second piece was around us being able to explore having that interface with the community and improving that, like we have done with the infection prevention control team. It's a North West Surrey integrated team. There's real scope to be able to do that with our harms-free care team, so we can see the benefit from trying to prevent harms out in the community and also within the trust as well.
Thank you. Sorry for having to answer the same question twice, but
that's fine.
It's important that it was aired at open board as well. And just finally to Marcin's point, really, and I think the performance report does it well now in terms of flagging up, and I'd certainly like to see the assurance, the ongoing month-by-month assurance around maternity, so that we've got, have we got partial assurance or full assurance in terms of our Ockenden report in particular. So I think that would be very helpful. Okay, great. Thank you. We're going to move on. We just got the quality of care November minutes. Jane, anything you wanted to say on those?
Just to say that they were received and approved. We did have the divisions at the November meeting, and so there were some actions for urgent and emergency care who weren't able to present due to operational pressures, but they did send a response via email, so that was good to have that engagement from the divisions. They were stood down for our meeting last week because of our requirements to be governance light at the moment to reduce pressures. At the meeting last week, the BAF scores remained the same. We reviewed it, but we felt that there was no indication to reduce, but also no indication to increase at this present time. We did have a summary report of the CQC inspection, just for the board to be aware of that, and we will at the committee obviously be monitoring actions against that at the next meeting. And we did receive, as we have discussed from the Audit and Risk Committee, we did receive the BDO audits in full at this meeting in December. And we had audits on falls, deprivation of liberty, surgical site infections and medical devices. And there was quite a bit of debate in the December meeting around the medical devices one in particular, and the findings of the CQC inspection and the key actions that need to be taken forward. Thank you.
Thank you. Any questions on those minutes? Okay, we'll move on. And David, I think you're going to put your old hat on for a moment and present the mortality review report.
Yep. Thank you, Andy. Well, we discussed this report at the Quality of Care Committee, so I suspect Jane may have some comments, but I will take it as read. As you see in the quality report, you can see that the mortality metrics that we keep an eye on and the average number of deaths that we have in the hospital is still within normal cause variation, and in fact our risk-adjusted mortality indexes are good. So the RAMBI is at about 91, and the SHME, which is the 6-month overall from the community, is 0.92, which is one of the lowest that I've seen in the hospital. Having said that, the mortality review paper is about learning and learning from deaths, and as Jane has already pointed out, the concern from the Quality of Care Committee, which is a concern that we all hold, is that the timely initial review is taking a bit longer than we wanted to do. So there is now a time frame that's set against that we need to do the initial review within 72 hours. And the structured judgment reviews are taking time to do, and we've fallen behind with that. Now, some of that is because of conflicting pressures. So the review team has been diverted to look at the nosocomial transmission within the hospital. Part of it is that we've been recruiting to the medical examiner's office, and we have got increased capacity now in there, and there's been some administration support which has been put in place. But the Quality of Care Committee asked us that we need to put a plan together with timelines on improving the timely review of this. And as you can see, when you look at the triangulation that I've reported in my report, this metric around the learning from deaths is flagging on our key performance indicators to demonstrate that it is something we need to improve going forward. Jane, was there anything else that I needed to cover in that, do you think?
I just, as on a positive side, I think we've now got a new mortality improvement lead that's going to February, the end of this month, and we've got a recruitment drive for further consultants to undertake the reviews. And from the COVID mortality work, we've recruited 3 new consultants already. So I think we have got some positive news in that hopefully going forward, we'll have some manpower to actually focus. And I think the improvement lead will be particularly important because it'll give that key focus. So I think that's a really good appointment.
Thank you, Jane. Questions on this report? Just, it's a bit difficult to see, but when I'm looking at the sort of paediatric mortality graph, it seems to be lagging in terms of, you know, up-to-date data. It's quite difficult to see, but it looks to me like the last one we've got is October, and given where we are now in February, why is that lag there? Why aren't we getting more up to date reports than that? Because we do get them for most things.
Yeah, I'm not sure, Andy. I need to look at that.
Okay, it's just that it's obviously really helpful for a board to have more up to date information. Really.
Yeah, good point.
So if you could just come back on that one, please.
Yeah.
Fran?
Thank you, Chair. I just wanted to make a point. I think that some of the really rich stuff that comes out of this whole mortality and morbidity view, since we've brought in the medical examiner roles, is the amount of patient experience sort of data and information you get just by talking to families and friends. It's particularly important for sort of end of life learning, etc., etc. And I was just wondering how we're sort of correlating that with our patient experience board and their agenda as well, to make sure that we've got that sort of cross-reference.
Yeah, I think it's a really good point, Fran, and actually the patient experience team and the medical examiner office work very closely. And in fact, we did, particularly during the pandemic, in the first wave and second wave, when the mortality was so high, they did an amazing job. And you're quite right, Fran. It's that early contact with the relatives and the family to talk through things. And the medical examiner's offices is situated adjacent to where we sit as executives, so I often go in there and talk to them. And they're a really upbeat group, and they often tell me how appreciated people feel, and also the fact that it happens really early in the process is so important. I mean, Andrea may know, because I don't know that we've seen that as an impact in terms of the complaints coming through later, because I think it does solve problems early, so that's what we expect. But it'd be good if we could look at that. I don't know what you think, Andrea.
I think anecdotally from the team, they've definitely had a positive impact in being able to deal with quite a lot of issues when they do a follow up with the relatives. But we haven't done anything, sort of any formalised sort of look at that, which we could do.
I think in my experience, when I was doing quite a lot of work nationally with the end of life care sort of teams, in England, that was one of the sort of offsets that came out from the medical examiners that I hadn't really appreciated for the end of life team, and how they sort of managed to maybe head off some of those really, very difficult complaints that families often have just by having those conversations. So I think it's really an important part of it, really, and really good learning. So.
I mean, Fran, it is one of the things that surprised me is from my consultant colleagues, which ones are really enjoying this work and gaining a different group of people than I would have picked, actually, I have to say. And I was talking to Rod Hughes the other day, and he was just saying how much he enjoyed that, and he loved looking through the notes and helping the patients see what had gone on and why because these families are grieving, aren't they? They've lost, and they want understanding and explanation and compassion, really. And the worst thing you can do is not talk to them for ages. So.
Yeah, really powerful. Thank you.
Yeah, I think Marcine's popped in the chat that on that report, then it's a Q2 report. But really, we should be, in February, we should be looking at Q3, to be honest. So that maybe have a look at the timings and see if it's possible to get things earlier. It might not be because of timings of committees and things, and appreciate just what the issues are at the moment. Andrea.
Sorry, Andy, it was just before we move off the quality section, it was just to highlight, I forgot to state about the at the Quality of Care Committee, we did review the Infection Prevention Control Board Assurance Framework, and just to reiterate that it was good compliance. We've still got good compliance against that. One of the areas that was flagging as an issue was lateral flow compliance around staff, and people maintaining that. So there's been a lot of work done within the trust in the last sort of few weeks, doing an audit to see where there was non-compliance, and then we've just sent out some comms around that to try and reinvigorate staff to make sure that they are doing that, because it is one of the key components really about preventing transmission, but also really good with surveillance as well. The BAF has been revised just at the end of towards the end of January. Just as the committee was sitting, a new edition of the IPC BAF had come out. There's been various versions of it. So the team, the Infection Prevention Control Team, are just going through that at the moment, and obviously we'll present that at the next Quality of Care Committee.
Thank you, Andrea. I'm 85% on my lateral flow, and that's only because I was away for 2 weeks in Thailand, and I got tested enough there, but I couldn't record it. So there's the example. Not perfect, but not bad. Right, let's move on to the performance section. So just before James comes to just give us the highlights, James, please. Please don't go through the whole lot. Merrick, I think Merrick's back on. Anything you want to tell us about the Modern Healthcare View of the Performance Report?
Well, we have been exploring it, as you'd expect, in detail in each of the committees, and there have been so many things done to improve performance generally, and our performance relative to some of our other colleague hospitals around the country has been good. Yet despite all of that, obviously we see continuing challenge, which is reflected in those numbers, and it is clearly not for the want of the work of all the people hard at it solving the problems. It is a question perhaps of we are where we are in the context we find ourselves.
Yeah, thank you. And obviously this goes to Quality Committee as well. Jane, anything to add on from your perspective? No, I think Jane's just off at the moment. Okay, why don't you give us your overall things you want us to look at, James?
Yeah, thank you, Tim. In terms, so it's been a busy month, and the context to this performance, without going into detail of all of it, is that it's difficult in the hospital at the moment in terms of operational functioning. COVID is been a challenging time, and whilst we don't have as many patients in the organisation with COVID as we've had through other waves, the challenge is very, very different and in many ways harder operationally, because we are now we're just a few weeks away from 2 years of operating through a pandemic. Where that's taken us to is a situation where it is much harder to have flow through and out of the hospital into community settings and home as it has been previously. It's much harder than previous times. So the pressure within the organisation is different and difficult. The pressures around workforce are different and challenging as well, and that's affected our performance in a number of ways. So going back into the Omicron from the end of mid to the end of December meant that we took down or reduced a number of elective services so that we could direct that resource internally at the ramp up of services. And in a number of situations, we haven't been able to turn those elective services back on completely yet, because the variant and the Omicron is ever present in the hospital and creating the pressure I've described. And so that is the backdrop really to where we are. In terms of restoration, the back end of December was affected by the fact that we had the Christmas break and we took the time down, as we would always do, but we took it down a bit earlier and we hadn't turned it back on as we would expect to. Sometimes we operate in between Christmas and New Year. We weren't doing that this year because of Omicron. That had been in our plan. We didn't know that there was going to be a COVID outbreak nationally again. So that affected our elective performance. Just to note there are some good things here that are worth noting in terms of electives. We are focusing on the urgent cases. So there's a slight rise in P2 cases, but you can see that they are being focused on. They're the urgent ones, or the more urgent, clinically urgent. Our waits over 52 weeks as we went into November and December demonstrated that we'd had grip as an organisation on that. We had plans to support the longest waiting patients. We have 90 over a year as we went into Christmas. That's the lowest in Surrey Heartlands and one of the lowest across the country. I'm talking to organisations who have got 3,000 or 4,000 patients over a year as other coups across the country. So relative, compared to where other organisations are, that's a good thing. I think operationally, restoration, I need to highlight follow-ups. So we've in the report, it's in there, the fact that it's overdue follow-up patients is a challenge for us. It's built up considerably during COVID to just over 12,000 patients who are overdue a follow-up appointment. Whilst we are taking people off of that cohort, more people are coming on. So that number has been static for nearly a year now. So before COVID, we were running around 2,500 to 3,000 patients that at any one time were overdue a follow-up consultation. Now we're running at over 12,000, and we haven't been able to shift that number down for the last 11 months. And the number of patients waiting over 6 months, you'll see in the report, continues to grow, and that's where it's focused on really challenged specialties. So that is something that we've discussed through the Quality of Care Committee as this paper has come up to the board. I wasn't going to say anything particularly about ED. It's through, as described, it's through the challenge through, and the metrics in the paper show very well the pressures through ED and through the hospital in terms of length of stay and the number of moves patients made. That's come down slightly. We can see that handover delays, although it's come down, it's still high from ambulances. It's a reflection of the pressure in and through the hospital. I have got to mention, in terms of diagnostics, the issues around endoscopy, ultrasound, and MRI. In terms of number of days, of course, we have bank holidays that we don't normally have in that month. This isn't about a plan or trajectory. This is just saying there are less days. The number of patients that we have over that target tends to go up when we have less days in a month to do the work. That is what happened in December. But also, we've got ongoing challenge in those areas. In terms of endoscopy, we have reached the peak. We believe now of patients on the list and begin to eat into that into January. We knew that we had significant leave. And Alliance, our support provider, who also run one of the endoscopy rooms, the modular one, they were unable to provide full service during December because of absence from their workforce. So that was a challenge we had. In terms of ultrasound, as I've described to the subcommittees and the board previously, we are still working up plans with internally and with outsourcing, insourcing providers of the quantum that we need to address our run rate and eat into the backlog. And the issue of MRI we describe in the paper that we are working through with our outsourced provider. We run that. That's a separate provider that worked for us to run our MRI services anyway. I wouldn't going to say anything more apart from in terms of endoscopy, we achieved JAG accreditation since the last board meeting, and that's the accreditation that endoscopy units have in order to, it demonstrates a level of compliance, and it's we've managed to retain that, and that's good. In fact, it's very strong and reflects the good work that teams have done in getting on top of the booking issues, some of the operational issues that we had there. Obviously, recognising we've still got the waiting time issues. I really see there's questions. Shall I take that, Chairman, see if there's any?
Yeah, let's take the questions at this point. Marcin?
Thanks, James. Obviously, I've been through this in detail at Modern Hospital Committee, but a few things have popped up since that I just want to ask you about. One, virtual outpatients. We're 10% off target. And that's not improving, and I just wondered why in relation to our thoughts about infection control and getting people off campus. Secondly, our P2s and our 52 waiters are actually on the increase, and I'll know this is backward looking and we had Christmas, but of course the next board meeting is not to the end of March. Can you give me a sense of forward projection, and have we got that back under control? And lastly is endoscopy. We have obviously had 2 goes at saying we'll clear the backlog, one by May and then another one, but where are we headed now, and what sort of assurance can you give the board that we've now got all the patients on the list and we're on target and we've got a trajectory to actually clear that backlog? Thank you. 3 important questions.
Yeah, thanks, Marcin. So what can you just remind me of the middle one? The virtual outpatients, the last one was endoscopy and the second one?
The P2s.
Oh, it was the P2 and the 52 weeks, wasn't it? Yeah.
Rather than because the Christmas period where actually was a decline in performance. Thank you.
Yeah. All those slight declines. So virtual outpatients, Marcin, so that's helpful because one of the issues that we've got, all providers have around outpatients, the national guidance around the thresholds that they're expecting are changing. So one of the challenges that they appear that virtual conversations have is they need to be challenged in the right specialties in the right way, and that's some work that we're trying to do. So for specialties where there's a lot of monitoring and a lot of chronic disease management, then these virtual clinics are working incredibly well. What we're working through, and we've adjusted our levels at the moment, because when we were very high, that we had to be through the peak of some of the COVID waves, we began to see, as other hospitals did, that there were consequences where clinics were run in specialties that it wasn't suited to. So what I'm trying to say is we could see that we were bringing patients back more often, and we could see that there was potentially it was fed back that there's an issue around diagnostic use. So we're very careful about that. What we don't want to do is increase either of those things, and that has reflected a more sustainable level of virtual outpatients. So we're under what the national target was at the start of the year. It's changed significantly as we've gone through the year. So that is recognised across providers.
Are you saying our 40% target that we set ourselves is now probably not a target that we actually want to have?
Yeah, it was the one that was set nationally, Marcin, and I think the one Simon can advise with me, but I think the forthcoming year is something like 25%. It's something. It's in that ballpark, isn't it, Simon?
Honestly, I can't answer that one, James. I'm afraid.
Okay.
Not confidently.
It's lower.
Maybe I can answer it to Marcin later.
Yeah.
Can I illustrate it with just an example, Marcin, about where a global target here probably isn't the right thing to do. So in cardiology, you can do remote follow-up, but what was happening was, instead of the cardiologist listening to the heart, which was taking about 5 minutes, the patient was then sent for an echo, in which they saw a person for 45 minutes having a diagnostic test to examine the thing that they should do automatically. So it's kind of the contractual giving results and all those kind of things, it's really perfect, but some of the other things, it's not so perfect, really. So we just need to, I think James is right, it's got to be specialty-based to deliver what the patient needs and everything. And clearly we've got to make sure there's access for everyone, and not everyone can access virtually. So we need to be aware of that as well.
Thanks, David. That's really helpful. In terms of the P2 and the P2 and the 52 weeks, so the P2, we are working very hard to retain that. The number of over 52 weeks is going to increase. So we have not restored our full level of elective operating at the moment. So Ashford Hospital has 2 elective wards, one of which we opened in April. The impact of where we are in terms of pressure within the hospital, number of admissions, has led us to use one of the wards there to relieve pressures on the main site. So we've expanded our non-surgical presence at Ashford into one of those wards, and that was a measure that we took during the new year, and we haven't been able to come out of that. So that's a real live issue. So I think next week so in February we're still going to be running at 2 or 3 theatres that we can't use at Ashford because we don't have the beds available to the elective side, and that's due to the acute pressures that we are still within that I've described. So when we can't turn theatres on, when we haven't got the capability because we haven't got the beds available to us because we're using them for non-elective pressures, unavoidably that the weights will come out again. However, we are still in a good position comparative to other organisations, and we are, to the extent where we are still looking, and we have longer waits in neighbouring hospitals, and we're still looking to support them in those longer waits. So we will be experiencing a growth in those over 52s, Marcin, but other hospitals, including neighbouring hospitals, have still more than we do, and we're looking to help them as well at the same time. So it's a mixed picture, but taken into the context of other organisations, we are achieving well. So well, in fact, that we're looking to help them at the same time as recover our own position. Does that answer that question for you? Thank you. And in terms of endoscopy, the timeline and trajectory will come back to the next Modern Healthcare Committee, which we agreed would be the process. And we have alluded to the fact that it's going to be the end of Q3, but we that is being worked through, because, as you say, there were some issues that have hit onto the previous timelines that we've had. I think your question around assurance was we looked at a number of ways that we can get assurance this time around. All of the actions that we're taking are having the right impact around booking, around pathway process, and utilisation of the units. We had, and one example of this is we had through the Cancer Alliance has an endoscopy support team. They came in and worked with us. They were on site with us 1 to 2 days a week. And they've actually moved away now, because our immediate actions, they believe we have a good grip, that the immediate actions around utilisation, around booking and process are in place. And they believe that we have got those key things in place. Now, what they are willing to do is to do some more work with us around some of the peripheral issues, and we're engaging with them on that. So one of the things is some of the clinical pathways that feed in and out of endoscopy, and some other bits that they think they can finesse with us. So we are engaging with that, but and we're taking up the opportunity to work with them and improve pathways further. In terms of the immediate thing, which we asked them to come in support with, they believe that we are on the right footing, and they don't need to have that much of a tight relationship with us on that piece. So that should provide some assurance, as should do the JAG accreditation that we've subsequently received as well. Thank you, Marcy.
Jane.
Thank you. Thank you, James. I was just really wanted to pick up the points that we were concerned about at Quality with regard to the endoscopy performance, which you talked about, the issues around the overdue follow-ups and the cancer performance. And I just wanted to provide the board with some assurance that the Quality of Care Committee were provided with around the clinical prioritisation, and that there's a very tight process around making sure patients are looked at, patients are looked at to make sure those that have the highest clinical need are seen as soon as possible. And I don't know whether you want to talk about that, James, because that was something we talked about at the committee.
Yeah, thanks, Jane. That's really helpful. Yeah, so that's why we had the priorities. So it's probably helpful just to say that when Marcy was just asking about the P2s, that we have a range of priorities that patients are given, P1, 2, 3, and 4. We actually have 5 and 6, but have been taken off now. They were to do with people deferring because they want to wait till COVID's over. So it's patient delay. Now we still have some of that, but the Department of Health have stopped us coding in that 2 ways, so we no longer show that bit. We just show the 4 categories. The important part is that all the patients that we know their clinical priority, they're in one of those prioritised categories, and that enables us to target the highest clinical priority patients. It doesn't necessarily mean the longest waiting. So we do hit the clinical priorities, which is at P2. Although we can see a little bit of movement, as Marcin demonstrated, the data shows how statistically significant that is, but it's still within the control limits of what we've experienced previously.
Thank you, James. And I think just to say that we monitor any patient harm, and there's a clear process for that as well. So that's important.
Yeah, there is, and very particularly around cancer as well, where we discuss that, the MDT discussion across the health community with primary care as well. But I think the point is, once we turn on our full elective capacity, we'll be able to get back on top of this to see the real challenge as the ongoing. We redeployed staff across a number of areas of the organisation. We readied ITU and critical care because we thought that was, that in all previous waves that's been hit really hard. We've needed to expand significantly. So we moved nurses and doctors to that. And we've had to redeploy nurses to the wards as well from those areas. And now that we've meant to move away from some of that pressure and realign staff back towards where they learning theatres up, it's still the bed pressure at the moment is such that we still can't turn all of that back on. So with 1 out of our 2 elective wards bedded for non-elective purposes, it continues to be a real challenge.
Can I pick that up, James? Because I mean, the whole point of Ashford, was number 1, green site, number 2, elective site. Now we've already got medical patients in Chaucer and Wordsworth, and pardon me for getting perhaps a trifle operational, but should we not, very shortly look very hard at saying, well, we cannot afford to actually take Dickens out as well, because we could be forever in this position, couldn't we? And unless we take some hard, difficult decisions, then our elective is always going to be falling behind. So I'm no clinician, and I can't advise on this, but I'm wondering, that do we have to take, from a system point of view, say those Dickens beds are just not available because they are doing something else, and that maybe if we're taking on patients from other places to do elective, then they could take some of those patients who potentially could be in Dickens. So maybe it's not for answering now, but I think the challenge is, how do we keep those elective wards going?
Yeah, I would like to answer you, Andy, because this is something we work on every single day. So this isn't something I haven't considered. I spend my days considering this with the team. So yesterday, another meeting, all the divisional directors, the clinical teams, again, about what we can do. The issue is how we balance risk. And when we're coming into an ED department that's got patients in the morning that we haven't placed, which you can see in the reports, because we haven't got the beds, when we're using our in-house cardiac unit, we've bedded into there, and we're bedded our discharge lounge. We're in all the escalation areas that we could be into in this site without causing significant issues on this site. So it is not something that we take lightly, and it is something that we really, really do need to get out of. But it is the impact of the society that the COVID pressures that are affecting society. That is where we are until we can sort out this flow through and out. And the pressures I've described, this is the consequence of it, and this is why it is considerably harder to run a hospital now than it has been through the previous COVID waves.
But those patients, how many roughly patients are we holding normally that could be either in a care home or in their own home or whatever in terms of numbers? It's far more than could be put in Dickens, isn't it?
Yeah, it is. But
so it's difficult. It is difficult. It is.
But while they're not in care homes, they're here.
No, exactly. Exactly.
The issue also around, and just to answer the question you alluded to around the hospitals that we are helping, we aren't helping any today because our elective centre isn't fully functioning. So we were only doing that when we can adequately do our own P2s, our own urgents. So that isn't something that we've been able to turn on this week or next week as we'd hoped to, because of the position we're in with ongoing pressure. But as soon as we can, then we will, support all the areas we need to. But at the moment, it's not an issue if they took patients off us, it'd be okay. That arrangement hasn't been able to work because of what we're describing here.
Yeah.
So it's not putting, I wouldn't want to give the impression that that's putting further pressure on the current bed situation. It's not.
So it's a system issue of moving people through, isn't it? That's the
That's definitely a big part. That's definitely a significant part of a range of factors that are coming together to bring about the current situation. Yeah.
Okay. All right. I think it's tough is the answer. There's no easy answers, and it's a balance of risk, as you rightly say. Okay. Anything else for Merrick?
Yes, so just kind of following on from that, and I remember a famous riposte the last time I asked a variant of this question, probably about a year ago, from Suzanne, which I think was something along lines we're not going to start thinking about having a care home in the hospital. Could completely get that, of course. But to the extent we have got people who usually should be in a care home, we're using, presumably, correct me if I'm wrong, but we must be using highly qualified clinical staff within the nursing cadre to look after them, and obviously that diminishes the availability of those staff elsewhere. Without getting into the game of running a nursing home, is there something that we could do where we do change the type of staff that we would normally have, and dare I say it, marshal them in, to Andy's point, into somewhere where we can provide a nursing home care rather than clinical care?
We have done a number of things along those lines. So we working with our social care partners, we've provided there's been a number of care homes that have been funded as block purchase beds that we could move people straight into whilst there's further assessment ongoing. There's a significant effort has gone into that piece of work. We've run Walton care unit very much as David described in his report, very much along the lines of you've described as a lower level acuity area, so that we can move patients to a less acute part of the hospital or part of our system. So we have done a number of those things, but the challenge still does remain.
Thank you.
Yeah, thank you. It'd be interesting to get some feedback, some more detailed feedback on how Walton has been performing and how that's helped take pressure off at some other point, James.
Yeah, I think it'd probably be through one of the sub boards.
Yeah, indeed, through the subcommittee.
Yeah, there's evaluation meetings of that going on actually that Andrew is aware of and Ernest on.
Okay, thanks, David. Any other questions for James?
Thanks, Jim.
Okay, thank you, James. Now, for the members of the public who are here, you'll note that there was a green plan on the agenda. Because that hadn't been properly through our subcommittees, we've taken that off here, and that will come back at some other point because it's a really important piece of work. But I'm just going to ask Tom to give a quick paragraph, if you like, on what we're actually what the process will be. Thanks.
Yeah, thanks. Pardon me. Thanks, Andy. All trusts have been asked to put together a green plan to be submitted in January, and we have compiled a green plan that is now subject to board ratification. This is part of the planning process for next year and will be built into the standard contract. And what we expect is that those green plans will then go into forming up a system-wide plan that we can work on with our system colleagues. We've got a team of people within the organisation who've been putting that together. We have had initial discussions on the green plan itself through the Modern Healthcare Committee and now at closed board, and we intend to have further discussion about that again at Modern Healthcare and possibly through Strategic Change Committee going forward before bringing the green plan back. So we're in the process. We're engaging with the system process around sustainability assurance, and meetings around that start within the next month. But we still need to go through a bit further discussion about the green plan itself.
Thank you, Tom. So there's nothing sinister in this. It's just that it hasn't gone through governance yet, and once it's gone through the subcommittees, we will obviously bring this to open board, because it's a great priority, not just for us, of course, but for the country. The NHS is a big green. Well, it's the wrong side. It's actually carbon producer. So it's really, really important that we get hold of this, but get hold of it properly with proper priorities, etc. So thank you, Tom, for that. So Merrick, Modern Healthcare minutes, anything?
Yeah, just a couple of things briefly. For this year, we believe that we will meet our numbers driven by the elective recovery fund in particular. The focus very much in the committee is looking forward and the significant higher run rate costs that are in our hospital and all hospitals now, and what next year is going to look like. I think all I will say is it's a very rapidly moving space that Simon is I think probably in and out of almost daily, and we will be watching this space very, very closely, and if required we will have subcommittee meetings out of sequence to deal with matters that we expect to rise over the coming weeks.
Yes, I think a dynamic situation is probably an understatement, isn't it, on this at the moment. It's different discussions coming down from region and national through the ICS, I guess daily, don't they, Simon? So
yeah, absolutely. We've probably had about 3 major conversations at different levels of the NHS just in the last few days, to be honest.
but we will bring it back as soon as it becomes clearer. But I think what is clear is that the COVID funding will obviously be withdrawn. A lot of the funding, the additional funding we've had, there will be different mechanisms, financial mechanisms for reward for funding us. We're just not clear exactly what those will be yet, but they will kick in from April. Okay, thank you, Merrick, for that. Any questions for Merrick on those? Thanks, Merrick. So, People Committee November, I think, was that you chaired that one, did you, Marcine?
I did. You've seen it. These were received at our last meeting last week and approved. The focus really, and I don't know if Aaron wants to speak. It's because you've heard Louise talk about, we were looking at where we're going to go with the vaccine issue and the flu issue. You've now heard that. We are also looking at our risks, because our risks, when you look at our current KPIs, we have low vacancy rate, but of course the vacancy reflects the establishment. And what you've heard with James and others is that we've had surge needs for staffing, and therefore we're much increasing our bank and agency, and that of course has the impact on finances. And of course COVID itself in the community has increased sickness absence, so our rates have gone higher than normal, but they're coming back down. But as I heard just yesterday, I think they're going back up. So the resourcing of the workforce still the #1 risks, because obviously that feeds everything. The issues are huge, but we felt that the risks have to now look forward, and our assessment of the risks, even though our KPIs might be green, we actually need to recognize the worn out nature of our staff, the increase on retirements, which was predicted, the turnover rate, which used to be quite stable, is starting to increase, so I think it's a picture of concern, which I think everybody here would recognize. And I hope that real quick jaunt through last in November, but also forward looking. And I think if Aaron wanted to add anything to what I have to say, happy to have him come in.
Thanks. And Aaron, just to be clear, Aaron is chairing at the moment until Dami comes back from maternity leave. So Aaron, anything to say?
No, I think Marcine said everything I was going to. That's why I put my hand down. But as she mentioned, in the last committee, we obviously just discussed the vaccine as a mandatory requirement. Obviously, that's now changed slightly, but nothing further. I think she's reflected upon the changes in, well, the KPI changes and how we discussed that regarding the BAF.
Okay. So, Andrew.
Yeah, I just wondered how we communicate out there for new staff, and it's just we found many years ago in Bromley by Bow it was very difficult to get GPs actually. When we began to communicate that actually we were about innovation and doing things differently and all, and that began to get out there, actually we had lots of really interesting people turning up at our door for all the right reasons. And I just wonder, we may be doing it, whether the communication piece with the outside world about what's happening, not just at Ashford and St Peter's, but around Northwest Surrey and stuff, because we just found that really interesting who turned up, and it wasn't just about the money. Yes, people get paid, but actually they were really interested in being involved in something that was about trying to make these systems actually work and deliver transformation and change. It's just a thought. It may be happening already, Andy, but I just wondered about it.
I think Louise will want to come in here. Louise?
Yeah, it's a really good point. Obviously, we now have a director of communications for the Alliance. Becky Fairburn was appointed a few months ago, and Becky's been working on a brand for a starting point in terms of what it means to be part of an alliance. I guess the next step for us is then, and how does that translate into recruitment materials and a different offer for people in terms of that employment experience. So yeah, it's definitely in our mind. We just haven't quite got to that stage of the branding process. And it's also about trying to find some examples of where we've actually done that, Andrew, to make it feel authentic and real. So again, there's a lot of activity going on at the moment within North West Surrey, as you know, so the community rebasing piece of work that's involving a lot of different providers and what might come out of that. We've got a workshop tomorrow around social care. So again, if anything fundamentally different in terms of how we approach workforce in relation to social care comes out of that, it's using those examples really, isn't it? So I think, yeah, great point. And maybe we'll come back to you just to get you to give some benefit of, you know, whether or not we're capturing that effectively.
No, very happy to do that, Louise. I'm very happy to talk to her about and join the dots a bit around some of this stuff and what we're saying nationally, because capturing that, I think there's a great opportunity, actually, I suspect.
I also think, you know, the links that we've been building with schools in the area,
exactly,
with Bourne and Brooklands College and all the rest of it, that we, you know, when we're ready, we need to use that, you know, as not as overt recruiting, but actually, you know, information, because the great thing is, you know, kids in school have no idea on the breadth of things that are available within.
And again, it's about you know, making sure that we do that at a time when we feel like we can show tangible change to how we engage with our school children, how we get them to come in and do work experience, and that feeling different to the traditional model, because at the moment the relationships are forming, but they've obviously took a bit of a back seat during the last wave of operational pressures. But yeah, good to remind us of that, Andrew.
Thank you. So I'm going to move on, mindful of time now, and obviously we've had a big program running on our strategy refresh, you know, with lots and lots of stakeholder engagement. And I asked Tom to come back to this meeting just with a verbal update on where we are at the moment on that refresh program that we're doing.
Yeah, thanks, Chair. So as you say, we're kind of towards the end of the process now, and we spent, well, the last sort of 6-7 months of last calendar year engaging with a lot of people, running a big survey. We had 15 overall sessions where we spoke to about 300 people, over 300 people, about our strategy and about their views and input to it, and how it needed to change to reflect new circumstances with the COVID pandemic, new policy framework that we're working within, and a range of other issues. And then we followed all that up with a couple of sort of sessions in December to get feedback on our findings and our proposals from the overall exercise. Where we are at the moment is we've been redrafting the strategy. The subcommittees have considered updates to the text of their, and in some cases the action plans related to their specific strategic objective, and they'll be built into the new strategy. The overall strategy will be considered at through the Strategic Change Committee during February, and then hopefully then move on to discussion at the Council of Governors in March for sign-off. In terms of what we've been hearing, I mean, we've heard an awful lot of very strong support actually for our existing strategy, and that's been really good to hear. And there isn't a big call out there for changes to the mission, vision and aims of the strategy, for the strategic objectives to change. We have had an awful lot of very detailed comments and suggestions, recommendations, ideas, and I mean a really rich degree of input into that, and all of that we'll be looking at and building into action plans going forward, and considering all of that. We've had a lot of support for the North Star objective, for the operating model that supports all of that, and we've been asked to build that into the strategy. In terms of emphasis, I mean, there's lots of areas of kind of, I guess, new and prioritized emphasis, much of which we talked about, the conversation we just had there about innovation, about how we access, how we allow members of our local community, children and people looking for jobs to come and access training, work experience, and to gain positions within, well, not just our organisation, but the wider health and care economy has been a really important part of what we've been doing. The nature of collaboration and the purpose of collaboration has been something we've discussed a great deal. We've talked about the importance of looking at the wider experience, and I mean, in fact, what we heard earlier on about the experience of, the improved experience that the preoperative assessment team, for instance, are putting in place is a brilliant example of the kind of thing that we want to then spread out to all of our patients and our community, and obviously use the technology advancements that we're making as part of that. So, communication, access, engaging with carers and seeing carers as part of the wider care team, the healing arts, the environmental agenda we've just touched on. All of these are being built into the strategy going forward, and as I say, we hope to bring that to Council of Governors for sign off once it's been through due process in March.
Yeah, and just to
take questions, and yeah, I've seen the clarification that you provided around the
yes, because obviously all board members are members of strategic change. What we would do formally is if we were happy at the end of the strategic change, then we would reform as the board to formally pass that. If we're not ready to formally pass it at that time, it wouldn't obviously go to Council of Governors for sign off. It would go for information on progress, and then it would go to the next Council of Governors. Any questions for Tom on progress? No. Good, thank you, Tom.
Thank you.
Right, we'll now move on to the regulatory section. Aaron, I think you're going to present the Freedom to Speak Up annual report, is that right? Okay.
Thanks, Chair. So the Freedom to Speak Up Guardian annual report enclosed outlines the activity and learning from the work of our Freedom to Speak Up Guardian, Erica Jarrett, in collaboration with the other departments. On a national basis, there's been a new Guardian appointed, Dr. Jane Chidji Clark, who has a background in nursing, a previous non-executive director, and Freedom to Speak Up Guardian herself. Our report compiles evidence from concerns received from a multitude of platforms, face-to-face, phone, incident forms, also includes information gathered through whistleblowing and more formal routes. The key learnings that we found from the outcomes can be bucketed into three themes, if you will. The first one being policies and procedures, the second one being attitudes and staffing, and third one being staffing, where most of the concerns sit in one of those three. Interestingly, the number of contacts or concerns raised made in Q1, Q2 in early 2021, 2022 was actually lower than our median being 24 concerns raised. Various hypotheses of why this could be, perhaps dealing with COVID pressures, diverted attention, or the time being able to raise them. Major themes for Q1 were in policies and procedures, followed closely by attitudes and behaviours. And in Q2, most concerns were actually in attitude and behaviours, and then staffing, and not policies and procedures. A noted issue that we is the volume of concerns that are reported anonymously. We discussed this at length at the most recent People Committee, and acknowledge efforts need to be made to encourage a more open culture in which people feel safe to report, an even more open culture, should I say, with their contact details made known. It makes it easier to try and identify the origin of these issues. The same goes for ethnicity data around who's reporting, with the majority being undisclosed as well. Erica has plans to address the aforementioned issues, including improved communication through teaching and published articles, but also to feature as a regular in induction material. Thanks, Andy.
Thank you. Can I kick off with a question? Because, and I don't think we've got an answer for it, but it's how do we get our staff to a place of confidence in the freedom to speak up, so that they don't feel, as we've heard about the whistleblowing to Cqc, and yet those concerns didn't appear on our freedom to speak up. So that to me means that there isn't a confidence around our freedom to speak ups. Because that should be your, if you don't want to do it through your manager, or you feel you're not getting traction through your manager and you're still worried, freedom to speak up should be the natural place to come, or indeed staff governors. And yet, so how do we build that confidence? I don't know if you've discussed that in People Committee, Aaron.
Yeah, it's a good question. I think it kind of stems back to the anonymous ratio of concerns raised. We did discuss it, and I think, like you say, there's no quick fix or known answer. I think it's going to take time for her work to be recognised through the communication channels that she's got, but also it's not singularly her responsibility. It's a group effort. So I think it's got to percolate through the departments that this is, first of all, an option for people to do, because it might be an awareness piece. But I think once we've excluded awareness, I think there might be, I think that's the first step, so make sure that people acknowledge that that's a space that people can pursue. Then I think other things can be considered. I don't know if Louise wants to add anything to that.
Louise, do you want to, before I bring Jane in?
I'm trying to use my words carefully. I mean, I guess part of the issue for us with the anonymous whistleblowing that went direct to the CQC was, I mean, it felt quite a kind of a orchestrated campaign by not that many people to do that deliberately. And whilst we continue to make the staff group in general aware of the opportunities to raise things within the organisation, people didn't avail themselves to those mechanisms, and we can't force that. I mean, and in fact, when it's done anonymously, we can't even identify who those people are. So I guess you're right, Andy. The anonymous nature of raising concerns for me, it is quite frustrating, because it means that it's very hard to get really under the skin of exactly what the issues are. However, that is people's right to do that, and we need to, as you say, continue to create psychological safe environments where people feel they can raise them. And there is more for us to do on the back of our staff survey results, on the back of this the CQC inspection, and the work that the team within, in particular GSAC, General Surgery, Anaesthetics and Theatres, have been doing around raising concerns and trying to deal with them in the moment. So, I mean, I'm not really giving you an answer. I'm just sort of trying to give a perspective on it.
Yeah, I'm not sure if there was an easy answer, I think we'd have already got there. Jane.
Thank you. One of the things we discussed at the People's Committee was looking at how we benchmark, if it's possible, against other acute sites, and also nationally, just to see if there are areas where they've kind of cracked this and where we can learn about how they're getting staff to not report so much anonymously. It may be that it's a national issue and we don't know. So that was something we discussed. Secondly, I think looking at the data, I think we can see that general surgery and anaesthetics as a division were quite clearly in the majority, although the numbers are very small. So maybe it was coming through as a division, but we didn't know the individuals, and so maybe we need to pick up that as an area for focus, where we get a particular division where we're getting more reports that are reported from that division. Maybe we can start to use that a bit more intelligent.
Yeah, thanks, Jane. And Chair, there is a very detailed programme of work from a culture refresh and OD perspective within that division to try and address some of the ways of working and feelings that people have in terms of teamwork. Okay. Andrea and David have provided quite significant leadership to that as well.
Thank you. Chris Kedley?
Yeah, I find this all rather frustrating, and I'm sure you do, Louise, and others, because I guess you have loads and loads of team meetings. I mean, I've seen them do ward rounds and walkabouts, and there's weekly meetings, sometimes daily meetings between staff, and you'd think these sort of things would raise up through those meetings, and there must be mechanisms that we have in place to capture concerns. So I didn't have a sort of answer to that. I just wanted to sort of raise that. But the other thing that really struck me about this in terms of the themes, if you sort of substitute policy and procedures with communication, those are exactly the three themes that come under the patient experience monitoring group in terms of concerns. It happens all the time. And it seems to me that there's a sort of similarity here, that it's a sort of almost like a cultural change in terms of people are afraid, are people afraid to speak up? Do we not have the right mechanisms for actually capturing it? So that we live in a culture of greater freedom of speech, I guess is my point. Just a reflection.
Yeah, absolutely. David?
Well, I suspect Andrew wants to come in, but we have done quite a lot of work along this as well to try and, as Louise says, when people raise things anonymously, it's really hard to get back to those individuals. So therefore, you have to get back to the team. And what we did is we put on quite a lot of team meetings where we discussed the issues that have been raised and demonstrated that they had been investigated, looked at, dealt with, and sorted out. The other bit that they did in the team, which I think is really, really good, they ran an engagement which was called Unmask Our Stories, which I think you've probably seen featured here. And actually, when they started running that, they got quite a lot of similar things to in the CQC, but actually, as that's travelled on, it's become much more positive. So people who've got positive things to say are coming through now as well. And I think that's a really good thing, because I think that helps builds the morale of the team. And I suppose the other thing that I don't want people to forget in this is that some of the impacts on some of the people who are targeted in some of these concerns that are raised, it's quite hard for those individuals, and we have to look after them in a way. And I suppose that one of the issues with this is that if an individual is targeted, and there were some individuals who were targeted on a frequent and recurrent basis and named the CQC, and if that's done anonymously, it's really hard for them to defend themselves, as it were, in terms of, or put their story through. So I just thought I'd put that in. We have to look after everyone in this, and I just want to make sure, because I have been worried about some of the impact on some of the individuals in that team.
Yeah. Thank you, David. Andrea?
Yeah, it's just I have been liaising actually with the Freedom Speak Up Guardian and Erica, and so I can see from the data that we've got, there's quite a number actually from GSAC, and I do know from what she said to me, the anonymous pieces that come through to her there's a lot that have chimed with what's been going to CQC, verbatim, same start, same things that are being said. So it is filtering through to her, and obviously we're addressing that through her forum, but also from the CQC perspective as well. What we haven't seen actually, and what we need to have a look at, is since CQC have been in, since they published their report, whether or not the whistleblowers have reduced, and actually Freedom Speak Up contacts have reduced as a consequence of that. We will find that out. But certainly the stuff that's gone through to Erica is from theatres and aesthetics is around the same things: communicate, not being engaged with, and policies. Felt that Ashford was unsafe, but obviously CQC stated that that wasn't the case, which was good. So yeah, similar themes.
Okay, thank you. Any other points for Aaron before we move on? Yeah, I think just a reflection that maybe Louise, in induction, we ought to be doing something specific around, I don't know if we do around that, but around the channels people have got, because they've got the staff governors, they've got the freedom to speak up, obviously got the managers. We all mention it. I mean, Suzanne used to mention it, I used to mention it, but it wasn't kind of focused in that sense. But so maybe there's, maybe I don't know, we could do something around induction around that. Because if you started induction, you've got a chance, haven't you, to to keep going. Okay, thank you. Simon, annual report and accounts, and more to the point, have we got an accountant?
Yeah, yes, I believe so. Although Marcin and Paul have been closing that out, I think they may want to add or confirm the timelines for the governors to approve that, but that should happen during February, I believe. Marcin, if you want to give me a nod.
So we've just received the finalized terms of reference and specification and fee. We went back with some questions, they answered them, and it's an excellent bid, and we've agreed it now. We've got to call in the governors and a meeting on the 14th of February where we'll ask the governors to formally appoint the auditors, and then they have got a detailed timetable of how they get up to speed. But this paper that you're about to present shows you the trade-off with finally getting an auditor at this very late stage and the need therefore to have late accounts. And that's the key issue that the board needs to recognize and approve and accept, although there are no alternatives.
So just to add to that, the accounts and the annual report processes are returning to a more normal environment post the COVID pandemic, really, in terms of requirements. Clearly, our accounts will be prepared and ready in the normal timeframes, but it's the audit that will be delayed, probably to sometime in September, late August, that kind of period. That's once they've got once Paul knows those dates, I guess he knows them now, we'll be able to notify the centre of that, really. But that's a 1-year agreement with the centre just to flex it for this year, to give everyone time to get up to speed and get through that, and to employ the appropriate teams to be able to service us in future, Andy. So
okay, and
yeah, it's a bit of a pain.
Just
but,
a sec. Clearly the board will need the details of the I know we have no alternative, you're quite right, of the bid, and is it a 1-year thing, is it a 3-year thing, or whatever, before it goes to the Council of Governors. So we just need a slot somewhere to do that as well.
We first need the audit committee to approve it. So
yeah,
Paul had a few days off, so we're just he's not back until today. So we will sort out the audit committee. Then we'll probably have to do it at a call. We are looking at a 3-year agreement with the option to extend for 2. Could I also add that we won't be the only trust in this position, so we will not be signaled out, and we do have an HSEI agreement for late accounts.
Thank you. And I know Sash, for example, have been in the same position as us. Okay, Simon, so we can take the annual report as read. Anything else you want to bring out?
No, not really. Obviously, if I sound a bit vague, it's only because I'm kept at arm's length from this process, obviously being the finance director of the organisation. So I'll just apologise for that. But
all right.
But yeah, it's working its way through satisfactory, I believe. Okay.
Any question? It's very good news, and thank you, Marcin and Paul, in particular, for all the work that you're doing on the auditors. I know it's not been easy, and Simon as well, of course. But at least we've got some. Good. All right. So we've received that trust seal. Simon,
did we miss the? Oh no, that's my order that's wrong. Apologies, my fault. The trust seal was relatively straightforward. It was we used the seal to sign off the Theatre 3 works, which is the fire damage theatre in Ashford. So that covers the contract and also the warranties that go with it. So just to note that, really.
Okay. Okay. Anything around the trust seal? Anybody? No. Thank you, Simon. And good. When will is that theatre back, James, now? Ready to go?
It's ready. It's ready to go. Yeah.
Yeah. No, I'm not saying that it's up and running, because of course we've discussed all that, but
it's handed back to the ops teams. Yeah, they're the clinical teams. Yeah.
Okay. Thank you. Right. Trust schedule of business, Sal.
Yes, again, straightforward, Chairman. We bring this every January for information and, well, to agree that forward schedule for 2022.
Okay, we've all had a look at it. Marcin?
So, Chairman, Sal and David, obviously the annual report is wrong and the quality accounts is no longer. So it needs to be updated and reflect the current position for our board and also just for the system as a whole, what's happening. And one issue that's always on the top of my mind, which you'll laugh, Louise and David, but the medical revalidation compliance annual report doesn't appear to be on this list. And I know it's something that needs to come to the board. So just curious as to where we put that. Those were my 2 points.
Thank you, Marcin. I'll pick those up.
And I think Chris Catley has made the point about digital as well. Digital is quarterly, not bi-monthly.
Okay.
Any other points? Nope. Okay.
Let's do audit, Sal. Audit is also now 5, not 4. We have increased our number of audit committees. Paul should be able to give you that.
It's the inflation. It's running wild in the country, as we know. Okay. So we now move on to any other business. I haven't been notified of any. And have we got any other points? No. So we have had some questions from the public, from Rosemary, who I was certainly on. Yes, she is on. So two questions there. The first one regarded Beth, and I think we discussed this earlier, that not as a board advisor, but we absolutely want to use Beth, as discussed with Andrea earlier, particularly probably on the patient side, because she's got such great insight on where the issues lie. So the answer to the question is that definitely we would be inviting Beth to help us out, and that is in progress. And of course, people who attend the staff story or the patient story are welcome, and I made the point the staff story today that they were welcome to attend. For the rest of it, they may choose not to. Certainly the staff today obviously had other things to do, and the patients from the patient story are always welcome, as anybody is, to stay on for the open board meeting. So that's the first question. The second one, Tom, could I ask you to have a look at that one?
Yeah, sure, Andy. Thanks, Rosemary, for the question. So just a quick response to that. Yes, we hear from Surrey and Borders that you're correct. The plan to use Headley Court has indeed fallen through. Clearly, the detail is not available from us, but there's a question to Surrey and Borders. The current plan in relation to the section 136 facilities is that they will move to Guildford, as you say, but they are going to be expanded. So there's another 2 suites are going to be provided there to deal with the loss of the suites whilst the Abraham Cowley unit is rebuilt, and obviously when that comes back online, those suites will be brought back. The site liaison team do continue obviously to work, and they will be housed temporarily within the St Peter's site in our offices.
And I think we would wish them to be permanently with us, wouldn't we?
Yes, absolutely. And
not our decision, but you know, we need to make them feel as at home as possible, so they want to stay.
Quite right.
So those are the answers to the questions from the public. Liz, we haven't had any other questions from the public?
No further questions, Andy.
Okay, so thank you for that. So reflection on the meeting. Anybody like to lead off on reflections on any of the subjects that we've covered in this meeting? Let me kick off, and I think it'd be similar to what I said at closed board, actually, that clearly we have a situation where we are probably under more pressure now than we were in the pandemic. It's a different sort of pressure, but it's cumulative. So we've got the 2-year issues for our staff, which, you know, is starting to manifest itself, I think, in various different ways. We've got, you know, the need to do many things at once. Obviously, cope with the people coming through urgent and emergency care and the beds, and we've talked about the bed issue, and obviously the system issue of how do we get people home quicker and better, because you know, it isn't doing them any good sitting in hospital if they could be sitting somewhere else, and that's something to be addressed by the system. And the need to get all our theatres in Ashford to get it back to being a truly green site and the elective side, and these are all interlinked. And my reflection is that, you know, if you just read the press, you have no idea really of what's going on inside healthcare organisations. And, you know, the press love to have a go at GPs have been on the firing list for a while now. But now it's, you know, back to waiting lists. And of course, the political spotlight is on waiting lists as well. But actually, there's a whole heap more going on. And it's just, you know, huge thanks, as I said in my report, to the whole team for the work they're doing. And that's every single person, because it's not just doctors and nurses or anybody else. It's every single member of the team is working hard. Simon. You're muted at the moment.
Yeah, apologies. I was only going to add that the challenges are immense, aren't they? You've just summarised those up, but the solutions lie with that partnership working across the whole health and social care system, really, and that's our focus, isn't it? Really, to drive this forward.
And I think we are committed as an organisation, as a board, and as an organisation to continuing, you know, the collaboration that Suzanne led us in, that we were all involved in, and absolutely at place, but also across the ICB and the provider collaborative as it grows. And I think it is the only way forward. Jane.
Thank you. I was just, I think it's very tough in health at the moment, and I really think that I wanted to thank all the executive team and all those that are working, you know, in the divisions, just for continuing to focus on the patient, because the feedback we had from the CQC was that people were being looked after well, and that is remarkable given the pressure that people are under, and I think we really need to celebrate that. And when we heard such a great staff story at the beginning of this board, how wonderful that people can innovate and focus on making the patient pathway better, even in these difficult times. And so I just think, you know, well done. I know it's really tough, but, you know, it's remarkable that we're keeping our focus on the right things at the moment. So I just wanted to say.
Thank you, Jane. Andrew.
Yes, well, I agree with all that, and I agree with what Simon's saying. I feel today it's just been a very even though there are all these challenges, all of which are real, it's been a very comprehensive discussion about all the elements of it, which I think has been, as far as I'm concerned, really good. I do think there is this whole thing about communication, even in the middle of that, the innovation that is going on, because it's going to be desperately important that across the country, because I can see what in other places around the country, some of this stuff isn't happening, and it isn't nowhere near where these conversations are at, I have to say. So I do wonder whether we need to position this more. And one of the things that certainly opened up in the debate with NHS England is creating a two-way street. So no longer can it be that NHS England has all the magic answers that we must then tick the boxes and all that. That is an out-of-date view of the world, that actually the micro and the macro need to learn to dance together. And I think whilst there'll probably be some pressures on that, I think it's that dialogue and helping colleagues in it to understand that's the nature of the relationship going forward, in my view, that needs to start to happen, because there needs to be real learning in the system. And as we've seen this morning, actually, in a micro level, there is real learning going on. The question is the system a learning organisation, and does it have any memory? And I think there is a real challenge in that, And I think there is memory and there is learning going on in Northwest Surrey. So for me, it's that two-way street thing, Andy, that we need to be bold about, I think.
David.
Yeah, I mean, I absolutely agree with everything that everyone said, and it all comes down to, it's all about people, isn't it? It's about patients and it's about staff, and I suppose my reflection is, I mean, Louise's team are completely stretched over such a big area, and we do need to get some more support and capacity in Louise's team, who are doing an absolutely tremendous job. But everything we've spoken about today has got some people or staff or patient element, and it's about doing that right and taking the opportunities that allows. So that's my big reflection, I think.
Thank you. And just as a final point, and I'd like to do an individual shout out actually, because Elaine Beaumont of the Louise's team has done just such a sterling job of being the face of Ashford St Peter's for both the chief executive recruitment and also the non-executive director recruitment. And you know, she gets on with things quietly and she really delivers. And certainly on the NED requirement, she has saved us, you know, heaps of money running that process. And we had a comment yesterday, I think from one of the non-executives, that said, wow, Elaine and her team do such a great job, you know, behind the scenes of being so efficient. And Elaine is that team. You know, there's no huge team behind Elaine. She does it herself. So, Louise, would you pass on our thanks?
Yeah.
To Elaine.
She quite often tasks me to do work, Andy. So I think I sit under her team as well.
Yes, yeah, but what a great impression. And the non-executives yesterday, at least 2 or 3 of them said,
yeah,
you know, what a great impression she gives of the organisation, the way she kind of handles things. So I
will pass that back, and it's a recurring feedback to her. So it's not just the last couple of recruitment exercises. It's something that you regularly feed back, and we are grateful for that. And yeah, I will feed that back to her.
Okay, good. So the next meeting will be the last day of March, which isn't actually that very far away because February is a short month. I want to thank everybody for their attention and their all the reports. I want to thank again the executive team for their extraordinary hard work. Remember, the non-executives are there to support you and lend a friendly ear whenever that is needed. And we will see you all shortly. Thank you.
Thank you. Bye.
Thank you. Bye.
Yeah, thanks everyone. Take care. Bye.
Bye.
Thanks everyone. Bye.